of the day with the code APSECON25 PPH OP03. I repeat, APSECON2025 PPH OP03.
Check. Test. Hello. Check. Test. Hello. Check.
Sir, ನಿಮಗೆ ಬೇಕಾ ಕಲರ್ ಬೇಕಾ? ಕಲರ್ ಬೇಕಾ?
Pointed. Slide more. Sir, slide. Thank you.
Hello. Good morning, everyone. Myself, Basaraj, Pharm D intern from BLD SSM College of Pharmacy. This study is KP study to assess the knowledge, attitude, and practice of emergency contraceptives among reproductive aged group. Emergency contraceptive of the safe and cost-effective measure which prevents unintended pregnancy. Population growth remains a critical issue due to lack of effective family planning leading to unintended pregnancy. Adolescents and young women are more risk at getting a unintended pregnancy due to limited access of family planning. There are some such methods, that is failure in barrier methods, improper contraceptive use, and lack of awareness and importance of emergency contraceptive. Unwanted pregnancies and unsafe abortions are the significant public health challenges. In that case, EC plays a very important role to prevent unprotected sex. Raising awareness and providing accurate information can lead to health risk and improves reproductive health and address complications from unsafe abortion. Primary objective to assess the knowledge, attitude, and practice of EC among women, and secondary objective to find out the relationship between social demographic characters and knowledge and attitude of EC, to find out the association between knowledge and attitude practice. Materials and methods. The current study was conducted for 6 months in OBG department in BLD College in BLD Hospital. The questionnaires include social demographic details such as age, residential, occupation, marital status, and number of children. They were asked the question for the participant, and we are recorded in the Excel sheet. And also the knowledge regarding contraceptives were assessed, and the opportunities were also used for counseling the women who did not know about EC. And also we checked the attitude towards EC, and these results are recorded in the Excel sheet through SPSS software. Inclusion criteria: the age group between 18 to 45, nulliporous women who are willing to participate in the study, and childbearing reproductive age group. Exclusion criteria: less than 18 and more than 45, women who have undergone permanent sterilization and refused participants, and the women who have went for MTP. Distribution of participants according to the level of knowledge. The participant in our study, the participant having poor level of knowledge regarding EC, that is 60, and moderate knowledge about EC, that is 36, and few of the having good knowledge, that is 7. Association between knowledge and practice: the participant may or may not go under practice, but they have good knowledge, or may not have poor knowledge. With a poor knowledge, the participant, they did not went for practice, that is 48. With a poor knowledge, the participant they are practicing, that is 12. With a good knowledge of participant, they did not went for practice, that is 30. And they are using with a good knowledge, these are 13. And the relationship between social demographic character of the participants and the knowledge of EC. Therefore, education status and occupation status are directly related to the social demographic, directly related to the knowledge. And the relationship between the social demographic details of participants and level of attitude. In this, education status are directly related to the attitude, level of attitude. Now, what are the factors affecting the knowledge of EC? Those are type of family and marital status. These two will affect the knowledge of EC. Discussion. Unintended pregnancy contribute to rapid population growth that impairs disparity, needed social and economic progress. In family planning program is not strengthened, the worldwide population will increase rapidly. The present study shows that 1.9% of the women belongs to less than 20 age and 98.1% belongs to more than 20 and 92.2% of them are found to be literate. Our study shows the minimum number of participants having had low level of knowledge. The present study also revealed that there is a statistically significant between knowledge and knowledge. The present study shows there is a statistically difference between knowledge, between level of knowledge of education and occupation. There is a statistically significant difference between level of knowledge and residency, and also there is a relationship between the age and the level of knowledge. There was no statistically significant difference that is agreed with this article. The present study revealed that the highly statistical difference between the attitude and level of education with a maximum men with positive attitude towards EC. As per the study conducted, it revealed the majority of women are poor knowledge of side effects of EC. Conclusion: emergency contraceptive is an effective method to prevent unintended pregnancy in case of rape, incest and contraceptive failure. Yet awareness remains low among women. Health education should focus on available methods, proper timing and potential effect to improve knowledge and utilization. Healthcare professionals should also play a crucial role in the providing awareness and provide a well-informed with positive attitude towards EC. The study found that 58.3% of participants had poor knowledge and emergency contraceptive utilization was minimum, highlighting the urgent need for education. Promoting EC through healthcare professionals and mass media can enhance awareness and accessibility for women. Thank you.
One question, sir, from my side.
Yes, sir.
And is there a direct relation between education and emergency contraception?
Yes, sir. Education and occupation are directly related to the knowledge.
But know that your statistical study that is showing only 12% of the educated women, they are practicing EC.
Yes, sir. We have taken only 1 or 3 participants. But based upon that, the result has came 12.
Right. Thank you.
Thank you, sir.
Any questions from the student side? Thank you.
Thank you. Before continuing the session, I'd like to welcome Dr. Nisar Ahmed, sir, Principal, Farooqia College of Pharmacy, Mysuru. Welcome, sir. I'd also like to welcome Dr. Shailendra Gurau, sir. Welcome, sir. I now call upon the code APSECON 2025 TKOP01. I repeat, APSECON 2025 TKOP01.
Okay, very good morning to everyone present here. I'm Amulya S., 4th family student from Sarada Vilas College of Pharmacy. I'll be presenting a topic on the theme traditional medicine with the title being The Legacy of Healing, Empowering Neurodegenerative Disorders Treatment Through Traditional Medicine. Coming to the introduction, neurodegenerative disease is the disease of nervous system mainly affecting the structure and function of neurons leading to their death. And here I put some major neurodegenerative disorders with their hallmark symptoms. First one being Alzheimer's, a progressive neurodegenerative disorder characterized by memory loss, cognitive decline, and leading to dementia. Second is Parkinson. As we all know, it affects the dopamine-producing neurons, leading to motor neuron disorder, causing tremors, rigidity, and bradykinesia. Next is Huntington's disease, which is a genetic disorder causing involuntary jerky movements and mood disturbances. And amyotrophic lateral sclerosis, it is a motor neuron disorder causing progressive muscle weakness and paralysis. Last is multiple sclerosis. It's an autoimmune disease where our immunity affects the myelin sheath, causing damage to the neurons and sensory disturbances. These are only the few of symptoms, and other symptoms include fatigue, pain, seizures, dysarthria, dysphagia, and many more. And next, here I put the projected trends and future risk about the global prevalence. As we can see, the current prevalence rate of Alzheimer's is now 55 million, Parkinson being 6 million, multiple sclerosis 2.8 million, Huntington 7 lakh, and amyotrophic lateral sclerosis being 4.5 lakhs. Here, as we can see the trends at 2030 and 2050, Alzheimer's will be thrice the current prevalence as now, and Parkinson will be double the rate as which is now. So why this chart I have put is, it's indicating the main risk. Because at 2050, many of us will be suffering from dementia, and we have high risk of getting these neurodegenerative disorders. That's why we have to start treating with the traditional medicine to prevent these neurodegenerative disorders. And main causes of neuronal death and damage is protein misfolding and aggregation, as seen in Alzheimer's like beta amyloid protein, and Parkinson as alpha-synuclein, and oxidative stress due to reactive oxygen species and free radicals, and mitochondrial dysfunction, excitotoxicity due to amino acids like glutamate or high calcium influx, and neuroinflammation due to inflammatory cytokines. Next, coming to traditional medicine, WHO defines it as sum total of knowledge, skills and practices based on theories, beliefs and experiences indigenous to different cultures, applicable or not, used for maintenance of health, improvement, prevention, and treatment. And here this chart shows the comparison of allopathy and traditional medicine. I have considered several aspects here. See that allopathy treats only the symptoms and not the underlying cause, and there is no halt in progression of the disease. But traditional medicine focuses holistically, targeting the prevention. And side effects is very significant in allopathy, but low in traditional medicine. Diagnosis is also often delayed. Cost is high, and there is only one-to-all standardized treatments, and it is very much limited by affordability. But as we see traditional medicine, it emphasizes early preventive care. It is very much highly affordable, available in low-income areas, and has high cultural acceptance. Now coming to the major traditional systems of all the countries. First is our Ayurveda from India. Coming from 3000 years, it uses processes such as Panchakarma, which combines 5 detoxicating procedures, which are Vamana, Virechana, Nasya, Basti, and Rakta Mokshana for removing the toxins from the body. Medicines such as Ashwagandha, Brahmari, turmeric, and Gotu-kola to improve cognitive function, memory, and which has antioxidant effects, which can help in several neurodegenerative disorders. Next, second being the traditional Chinese medicine, which ranges back to 2500 years, uses processes such as acupuncture, that is inserting fine needles to the meridians to enhance the blood flow, and Qigong, which enhances the vital energy Qi, which is from China, and Tuna is a massage therapy for improving the blood circulation. They use several medicines such as ginkgo and ginseng and huperzine A, which possesses high antioxidant and neuroprotective effects. Next is Unani medicine. This is the combination of Hippocrates medicine with the modern Arab medicine. They use processes which are Ilaj bil Tadbir, that is regimental therapy, and Ilaj bil Gija, which is dietotherapy, and Ilaj bil Yad, which is surgical therapy. And main herbal medicines used are Brahmi and saffron for their neuroprotective effects and cognitive improvement. American medicine containing healing ceremonies and herbal medicine. They use sage and sweetgrass for purification and for calming and protective effects. And African medicine using Kigelia africana, hypoxis and moringa for anti-inflammatory and antioxidant activities. And European medicine using St. John's wort, lemon balm and hops to elevate anxiety and for its calming effects. Now the last one, Aboriginal medicine from Australia, which uses kakadu plum, which is rich in antioxidants, and eucalyptus for its anti-inflammatory activities. The way all these drugs are acting, the key mechanism is antioxidant effects, anti-inflammatory and neuroprotection, and enhanced blood flow. This is the final assessment chart which I put based on the symptoms, the herbs, and their mechanism. Like for protein misfolding, we can use curcumin from turmeric or huperzine A, saffron. For oxidative stress, we can use Brahmi, ginkgo, etc. Like which I had explained the symptoms and mechanism, we can use such drugs. Now coming to main part, the clinical studies and research. I have put 6 of the major research which I have got. First is ginkgo biloba extract in dementia study details 2024.
Okay. Thank you. I have one question.
Yes, sir.
So you are saying that through use of natural products,
Yeah.
you can not cure, you can improve the condition of the Alzheimer's patient.
Yes, sir. All
Okay,
neurodegenerative disorder, like there will be several symptoms in neurodegenerative, which is causing is like there will be mitochondrial dysfunction or protein aggregation and few such which will cause the neurodegenerative disorder.
One
By
minute,
using,
one minute. And what may be the mechanism of improvement in the memory in Alzheimer's disease?
sir,
You are saying that natural
Yeah.
products. What may be the mechanism?
sir, mainly like Alzheimer is caused by amyloid aggregation, and there will be neuroinflammation which will lead to neuronal death. But when we use the traditional medicine, the amyloid plaque formation will be decreased, so there is no chance of aggregation, and even the inflammatory cytokines will be suppressed. So and also neuroprotective effects are also seen. So there will be no Alzheimer's disease, sir. It can improve dementia.
Is there no role of acetylcholine?
Yes, sir, it will balance like huperzine A, it acts as an acetylcholine esterase inhibitor coming from traditional Chinese medicine. So it can act as the drug which we use.
Okay, thank you.
Thank you.
Thank you. I now like to call upon the code APSECON25 PPH OP06.
I'm Tejaswini. I'm 4th B.Pharm student from Sarada. Today my concept is patient safety, global challenges and ethical considerations. Introduction to patient safety. Patient safety, though the concept looks so simple and random, it is very important in the health sector because patient safety becomes more important and it plays a huge role in the healthcare sector. It is that we should not cause any harm to the patients because it is our dignity to maintain the patient safety, being a healthcare professional. Ethically, it emphasizes on the principle of non-maleficence and beneficence. Non-maleficence is not to cause harm to the patient, and beneficence, it is promoting the well-being of the patient and to respect their patient and to respect the patient autonomy. That is, we should respect their decisions regarding their own health care. General objectives of patient safety is to improve their safety first, because it is important to comfort them with healthcare professional, and specific objectives are preventing harm, any kind of harm that happens by the healthcare professional, knowingly or unknowingly we have to prevent them, and reducing errors or risk such as ADRs. If we can reduce it by some medications to any cost, we have to do that. and improving the quality. By any means, if we can improve the quality of life, it may be like social factor, economic factor, or looking their economic factor also. Sometimes cost also is an important factor for a patient, and like their mental emotions, we have to respect everything. And enhancing communication, the patient and healthcare professional should have better communication, so that they'll become more comfort with the healthcare professional, so they can share their personal health issues with the doctors or pharmacists or any healthcare professionals. Factors influencing quality of life. Actually, errors are the main causes of harm to the patient, like medication errors. It may be due to any kind of medication, and surgical. It is due to the failure of surgery, and diagnostic errors. It may be due to the failure of the diagnostic tools. Medical device errors. Medical device errors may be due to surgical instruments, and infections and blood transfusion. Factors that influence quality of life are treatment, psychological factors, physical, economical, social, and disease state, ADRs. It may be by minimizing the ADRs, we can influence their quality of life. Global challenges in patient safety. Medication harm can be avoided in health sector by elderly patient care units, intensive care units, highly specialized surgical care, and emergency medicine. And with proper communication and intercollaborative work among the healthcare professional helps to overcome the global challenges in patient safety. WHO guidelines have taken 3 challenges. Those are clean care is safer care, safe surgery save lives, and medication without harm. The third challenge is the most important one. It is very important for us, the pharmacists, because we are the one who play a very major role in medication without harm. Ethical considerations in patient safety are patient autonomy, that is to obey the patient's right about his own health care and to maintain the confidentiality, and beneficence to promote their well-being, and non-maleficence is not to harm. And other considerations are believing in their cultural backgrounds and beliefs, and conflicts of interest is to not involve in their personal matters. Conclusion is that patient safety is a critical global health issue. So every healthcare professional should be more precise and more careful about patient safety. And legally, they have to follow the principles of non-maleficence and beneficence. They should be more communicative among themselves, and should always prioritize patient safety. Thank you.
Yes, so a good topic of us. Can you please highlight about the medication error, how we can overcome it?
Like, we have to look to the medications which have least adverse effects, and we have to tell them timely administration is very important in the medication to the patient. If they don't take according to the time, it will be a problem. So we have to inform them to take time to time their medications, and proper diagnosis is always important for a patient. So they both play a very important role, medication and diagnosis.
Medication error includes look-alike, sound-alike drugs, mismatching dosage, frequency, lot more to highlight. Anyhow, good innovative topic for the present generation.
Thank you, sir.
Thank you. I now call upon the code APSECON 2025 ST01. I repeat, APSECON
Okay. Very good morning, everyone. I am Anirudh Joshi from National Institute of Engineering, Mysuru. Today, I'm going to be giving a presentation on wearable and portable GPS solutions in dementia management, perceptions and challenges, a study on attitudes of family and personal, professional caregivers. So let's get into that. Yeah, so this is the table of the presentation which I'm giving. So firstly, we will cover what GPS basically is and what dementia is. And then why is GPS required for healthcare of dementia patients, and what is the impact of GPS technology, and what are the advantages and disadvantages, what are the hurdles right now, and what are the solutions for those problems. We will look into that. Yeah, firstly, what is GPS, that is Global Positioning System? Please do make sure you look into this video while I explain. GPS, that is Global Positioning System, is a space-based radio navigation system that provides positioning, navigation, and timing services. It uses a constellation of satellites in the Earth's orbit to calculate a user's position and time. Right? The satellites are arranged in such a way that a user can see at least 4 satellites from almost anywhere on Earth. So tonight, if you are free, and if the sky is clear, just go out, look up, you will at least see 4 satellites around you. So here you can see the increase in number of satellites over the years, right? And it is increasing exponentially. So yeah, what is dementia? I think everyone here knows what dementia is, right? Dementia is a general term for a group of conditions characterized by a decline in cognitive function, particularly memory. It results from the damage to brain cells. So here I have an image of healthy brain cells. Here we can see the size of the neurons is good and the size of the brain content is good over here. Whereas if I consider Alzheimer's disease, which is one of the conditions or one of the disorders in dementia, the neurons starts dying, it starts shrinking. So neurons are the ones which hold the memory, right? As it starts shrinking and dying, all the memories which are present inside the neurons will deteriorate, which is very dangerous, right? As of now, there is no cure for dementia, but it is currently being worked on. So these are the different types of dementia. It includes Alzheimer's disease, vascular dementia, and frontotemporal dementia, alcohol-related brain damage, Parkinson's disease, and posterior cortical atrophy. These are the 6 top types of dementia. Nextly, why is GPS technology required for dementia patients? This is important. Firstly, we have safety and security of the patients, right? And then peace of mind for the caregivers. Okay. And next, we have emergency response. If they leave a particular area around them, an emergency response will be sent to the patient as well as the caregiver. And independence and quality of life of both the patient and the caregiver. Okay, what are the advantages? We have caregiver support, informs care decision and reduces supervision, improved health care, research and development, and community integration. What are the disadvantages? Obviously, there will be privacy concerns, potentials for misuse and surveillance, ethical considerations, technology limitations, battery life and signal strength, so on and so forth. As of now, it's not perfect, but it's been worked on. So this is the study which I conducted. So I visited various Rotary clubs in Mysore. I collected the data by form filling. This is the form which I provided to the patients or to senior citizens, right? And I almost took 150 data from various senior citizens of Mysuru. And yeah, the inclusion criteria is male and female more than 45 years, and the exclusion criteria is less than 45 years. Yeah, so these are the key takeaways of the study which I conducted. Many caregivers were not aware of the trackers and their availability, and they face enormous difficulty due to wandering of the patients. This is very dangerous as of now. In India, there is a lack of robust support systems like those which are found in Western countries, where helplines are readily available and police departments respond promptly, right? Yeah, these are few photographs. I also conducted digital device awareness initiatives at Pejawar Shridama and JP Nagar and other Usuru foundations and Rotary clubs in Mysore. Yeah, here you have some pictures, and yeah, this was from Government Yoga and Naturopathy College in Mysore and Vatsalya Foundation in Mysore, and this is from Rotary West, which is at Saraswati Muru over here, in JSS Medical College, Rotary Midtown, and Krishnadhama. Very important thing is many people from medical colleges and government colleges did not know about these tracking devices. They thought that it was only meant for mobile applications, but that was not the case, right? So in conclusion, my study said that raise of awareness about elderly care through effective communication and education is very, very important. Empower senior citizens with user-friendly technology while ensuring technical expertise and maintenance. Prioritize compassion, emotional support and social engagement for senior citizens. Improve elderly quality of life by addressing societal gaps and health concerns. Thank you very much.
One of the very good innovative topic you have done, a need of the Havas at this situation. Suppose GPS tracking is, as you told, some mismatch or tracking, any alternative method is available?
Yes, sir. Not only GPS technology, we can also use Bluetooth technology and radio technology for that matter.
That will alert the patient if they deviate the routes or whatever is there?
No, that won't happen. GPS is the most accurate as of now, but the misuse in the sense there won't be any fault with the technology, but some other people can access their data. They can get to know where the patient is right now. They can hack into the server which they are using. Right? That is the privacy concerns which they have. But GPS technology itself doesn't have any fault right now.
Very, very innovative topic. Yeah.
Thank you, sir. Thank you very much.
Thank you. I'd also like to thank Dr. N. Venkatrao sir, Dean of Pharmacy, Sarada Vilas College of Pharmacy, for evaluating the session. Along with, I thank Dr. Nisar Ahmed sir, Principal, Pharmaceutical College of Pharmacy. Thank you, sir. I request Dr. H. Joshi sir to hand over a token of appreciation to our evaluators. Thank you, sir. Thank you, dignitaries. Let's continue our today's scientific session. May I now welcome Dr. Gnanachandran sir, Professor and Principal, Pranav Institute of Pharmaceutical Sciences and Research, Gwalior, Madhya Pradesh, and Dr. Devika ma'am, Principal, Sarada Vilas College, Mysuru, to chair the session. I welcome Dr. Shailendra Gurav sir, Professor, Department of Pharmacognosy and Phytochemistry, Goa College of Pharmacy, Goa University, Panaji, Goa, for a talk on Ayurveda Biology and Integrative Approach in Health Management. I request our speaker to kindly occupy the seat on the dais. Professor Dr. A.K. Gnanachandran sir is a professor and principal of Pranav Institute of Pharmaceutical Sciences and Research, Gwalior in Madhya Pradesh. Sir has over 41 years in academics and was awarded with Amrita Institute of Medical, was awarded by Amrita Institute of Medical Sciences and was awarded with Best Pharmacist Award from Ministry of Health, Kingdom of Saudi Arabia, and Lifetime Achievement Award, Madurai Medical College by Alumni Association. It's an honor to have you with us today, sir. Welcome, sir. Dr. M. Devika ma'am is the principal of Sarada Vilas College, Mysuru. Ma'am joined Sarada Vilas in the year 1992 and became the head of the department in the year 2002. Then she became the principal of Sarada Vilas College in the year 2020. Ma'am has completed over 33 years of experience in Sarada Vilas alone. Ma'am obtained her PhD from University of Mysuru and is actively involved in research since 15 years. It's a pleasure to have you with us, ma'am. Welcome, ma'am. I now request our chairpersons to kindly introduce our speaker to our gathering.
Very good morning to our President Milind sir and our Secretary Hanumanta Joshi and all the dignitaries of today's function, as well as my dear young students. I take pleasure of introducing Shailendra Gaurav, who is a professor, Department of Pharmacognosy and Phytochemistry, Goa College of Pharmacy, Goa University, Goa. You know, the Goa College of Pharmacy, what are the first college? First college.
It is one of the first college in Asia. Establishment is in 1864. 1864, yeah.
Dr. Shailendra S. Gaurav has done a lot of research activities in natural products, nanomedicine, pharmaceutical biology, Ayurveda biology, and pharmaceutical biotechnology. And Dr. Shailendra Gaurav has a lot of awards to his credit. He is recognized as the world's top 2% scientist. And Dr. P.D. Patil National Award. And Dr. Shailendra Sarab has got experience of about more than 15 years in academic and research in about 5 years. And he has got 19 patents, international 5 and national 14. And he has done a lot of publications and books, 5 books, and pharmacognosy, phytochemistry, antibiotic drug discovery from natural products, Indian system of medicine, laboratory manual of pharmacognosy, Indian herbal drug microscopy. So he has a lot of experience in research and academic, my dear Shailendra Gaurav. We are happy to introduce to you.
Thank you.
I am happy that you got a lot of awards also, world's top 2% scientists. So with this introduction, I hand over the floor to you, sir.
Good morning, everyone. Thank you so much, Professor Ganachari sir, for introducing me. Without wasting much more time, I will directly start with the presentation because organizers have given only 30 minutes. So we have to try to wind up within 30 minutes. If you see the title, that is Ayurveda Biology, an integrative approach in health management. Ayurveda Biology, being a pharmacognosist or a pharmacist, we only know the term Ayurveda. And when we think about Ayurveda, we know Ayurvedic medicines, specifically medicinal plants. But Ayurveda Biology, probably some from audience might have heard this term first time. Biology, we know the biological process. So what is the correlation of Ayurveda with this biology? Ayurveda is not dealing with only medicinal plants or some herbal formulations, but at the same time, some biological processes involved in those biological Ayurvedic formulations. What is the science behind that? And what is the need of the same in today's era? If you see, Ayurveda, it is a holistic approach. Wellness or the well-being, when the person is called he is well by his health, what we understood, wellness is not a mere absence of a disease condition. It is a complete wholesome state of a person's complete physical, social, as well as psychological behavior. If you see the World Health Organization defines health. Health, it is a condition or the state of complete social, physiological, and psychological state. Whereas wellness, it is a process. It is a process of getting a person aware of his social existence. In short, health is just for the well-being, whereas wellness is enhancing the well-being. Today, in modern science, there are the two schools of thought, sir. Two thoughts, which are those two thoughts? One is a holistic and other is a holism and other is a reductionism. Holism means what? Holism, again, it is a state like a WHO. Holism, it states, it is a state of a person with its complete social, psychological, behavioral, as well as a spiritual life. Whereas reductionism, it is a study of processes. Which processes and how? Process of destructing the complexities of the health. Destructing the complexities of health at molecular level. And today's modern science, it works on that reductionism approach. Whereas Ayurveda, it is completely holistic approach. And in today's era, there is a need of holism as well as reductionism go hand in hand. So how is it possible? That is possible with the help of Ayurveda biology. If you see Ayurveda, what is the meaning of Ayurveda? As we know, Ayur means life, and the Veda, it is a knowledge of life. But at the same time, when Ayurveda, it is one of the oldest Indian system of medicine, but it promotes, it intended to promote the health rather than fight a disease. Rather than fight a disease. That's why I'm repetitively speaking, it is about wellness, not only about the health. These are the different treatises of Ayurveda. You can say these are the Bibles of Ayurveda. Atharvaveda, Charak Samhita, Sushrut Samhita, Ashtanga Hridaya, Maitreya Medica, Sharang Samhita, Madhav Nidana. Ayurveda, it works on these 5 principles: earth, Prithvi, Jal, Tej, Vayu, Aap. That is earth, water, fire, air and space. How it works? Because it considered the body as a microcosm, reflecting the universe with interconnected system influenced by natural elements. At the same time, it needs to study, or Ayurveda study, about the mind and body connection. Ayurveda, it is based down on 3 doshas. That is Vata, Pitta, Kapha. Ayurveda treat a person, or it's a disorder, based down these doshas only. And as I mentioned, Ayurveda biology, there is a need of a integration of that holism and reductionism with the help of Ayurveda biology. How it will help? It will try to help or bridging the gap. Evidence-based integration. Most of the Ayurvedic formulations, they are already reported or they are already used by Ayurvedic practitioners based down the literature or Ayurvedic text. But most of the times, they have not the scientific evidence or they are not supported by the research evidence. And medicines to establish the scientific evidence. When we talk about Ayurveda, it always deals with the medicinal plants, either maybe single plants or the polyherbal. Polyherbalism. What is the power of a polyherbalism? The component and how exactly it works. Why the polyherbal formulations are supposed to be better than the single herbs? Because most of the time the rationale behind this is it gives the synergistic effects. The potency will be increased because of the multi-component part. The other components will be also add to the additional pharmacological activity to the therapeutic efficacies, and also it helps in improving the palatability. Ayurveda biology, this concept I am going to discuss with reference to one of the case study which is carried out in my lab by one of my PhD students, that is the Grita formulations. Grita is nothing but a cow ghee based herbal formulations. When we are talking about Grita, we need to understand there is a special significance or the special place of a cow in Indian system of medicines. In Ayurveda, cow is revered for its holistic healing properties, and it has 5 products which is also known as a Panchagavya. That is a cow milk, urine, ghee, curd and cow dung. And they are already traditionally used for different disease elements as well as some other purposes like some cow dung, it can be used to prepare the insect sticks as a mosquito repellent, not only medicinal purpose, but some other purposes also. These are the 5 products. Milk, which is generally used for various skin diseases, constipation. Recently, its anti-cancer potential also, it has been reported. Ghee is there, it is for constipation as well as anorexia and skin disorders, specifically in the wound infections or to heal the wounds. Then curd, treat fever, edema as well as blood disorder, and the cow dung, which is supposed to be a waste product, but the manure and insect sticks, they are prepared by using cow dung. What is the significance of a cow ghee? Out of those 5 products, now we will focus on the cow ghee. Why specifically cow ghee has a special significance? In modern science, we know the lipid-based drug delivery system, so-called liposomes are there, phospholipid complex are there. In today's era, we call it as the lipid-based formulations are novel medicines. But in Ayurveda, our forefathers, they have reported the significance of the lipids a long time ago in the form of a cow ghee. Why? The cow ghee is considered a premier Ayurvedic rasayana, which promotes longevity and overall well-being. It deeply in the penetration of those particular herbs with which it will be mixed to the core part or the targeted delivery. It is considered as a versatile agent and it enhanced herb potency. What is the meaning of it enhanced the herb potency? In case of a Grita formulation, when you are mixing a particular herb with cow ghee, it will not only deliver that particular herb at a targeted site, but at the same time, it will enhance its efficacy also. How it will enhance, that we will see in our case study. So Grita, it is basically an Ayurvedic dosage form, and the preparation of the Grita formulation is known as a Grita Praka. Processing of a ghee with herbal decoction. It may be herbal decoction by boiling the herbs with the water or by using the fresh herbs as per the Ayurvedic text. Now see, the Grita procedure, you cannot prepare the Grita as it is. You need to follow the Ayurvedic norms, Ayurvedic text. That procedure has to be followed as per the Ayurvedic text only. It can be used for the internal use as well as for the external use. What are the clinical applications of a Grita? Already several Gritas, for example, Ashwagandha Grita, Brahmi Grita, Kamdev Grita, then Guduchi Grita, Triphala Grita, all Gritas are already reported for their in the treatment of cardiovascular health, for their neurological benefits. They have the immunity modulatory effects. Ghee, as we know, ghee itself is used to treat the wounds as well as some wound healing herbs. When you are preparing some formulation by using wound healing herbs, they can be used to treat the wound, then gastrointestinal disorders as well as the skin conditions. These are some of our lab research which is on the Grita formulation which is published. You can see here the first one, that is a Ashwagandha Grita. Ethnological validation of Ashwagandha Grita as a Vajikaran Rasayana. Ashwagandha drug, it is already reported or it is proved for its aphrodisiac potential. And it is also called as Vajikarana. In Ayurveda, the term is for aphrodisiac category, the term is Vajikarana. So we have established the Ashwagandha Gritas, that is aphrodisiac potential, by in silico, in vitro as well as in vivo study. Again, when I am talking about the integration or developing of a scientific evidence, what does that mean? Already Ashwagandha Grita, it was already reported in Ayurveda as a Vajikaran Rasayana. Just we are producing the scientific evidence for the same. In the same way, this is a Murchana Samskara. In Ayurveda biology, Murchana Samskara, what is the meaning of Murchana Samskara? In case of allopathic drugs, we know some drugs have a small shelf life. There are the certain ways in a modern medicine to enhance the shelf life of those drugs. At the same time, to enhance the therapeutic efficacy of drug. Specifically, in case of drugs which have a low viability, in that case, you can enhance the therapeutic efficacy. But in Ayurveda, certain biological processes are there which will enhance the shelf life as well as the therapeutic efficacy of those drugs. And this is one of the process, that is a Murchana Samskara. Murchana process, where is the use of antioxidant herbs to enhance the shelf life. This is completely novel formulation, that is a Bhala Takadi Grita, which is developed by one of my student. We already filed the patent for the same, and we published the paper also for the same one. That is a Bhala Takadi Grita. And the same herbs or same Grita that we established its evidence for its wounding activity. Then this is a classical Ayurveda formulation, that is a Kamdev Grita. This is Ashwagandha Grita with reference to its Murchana process. And the word is mentioned here, storage condition. Now again the thing is, in ancient days, some plastic or glass containers were not available there. At that time, most of the time, those Grita formulation, they were stored in earthen pots. So what is the effect of those storage conditions on a Grita? That also we have studied and we have reported in this paper. And this is the, with reference to the study, with reference to Murchana and Shatadhuta process. One of the additional process or one more process, that is a Shatadhuta. Shata means 100, Dhautta means washing, 100 times washing of a ghee. And then it is used for the preparation. So what is the benefit of the same process that we will see in our case study? This is the case study which I am going to discuss. So probably some PG student as well as UG student, they can look at this case study as one of the research work which they can follow also by following the Ayurvedic text. A case study, that is a polyherbal Bhalatikata Grita, formal development as well as evaluation. The first thing which we did, that is a procurement and standardization part. The plant material to prepare that Bhalatikata Grita we selected. Now which plants we selected? We selected the plants which are mentioned in Ayurveda as well as which are already reported for its wound healing potential. Those plants were collected from Western Ghats and they were also standardized. These are the 4 different plants which we selected. That is a Semicarpus anacardium, belongs to Anacardiaceae family. It is also known as a biba. This is a Vasanvale, Cocculus hirsutus. Then Argemona mexicana, Mexican prickly poppy, and this one, that is a Dhataki, Woodfordia fructicosa. These 4 plants which we selected for our study. This is as a standardization parameter, microscopic studies which we done. You can see in Ayurveda, whenever some toxic drug material are there, then one process is mentioned, that is a Shodhana. Shodhana is nothing but a purification. The drugs, that is Semicarpus anacardium, which is also known as a biba, it is having some toxic principle. That's why I need to subject it for the purification. That is a method of Shodhana. If you see the procedure, I will just discuss this procedure only, not the rest of the procedures. The thalamus portion of the collected fruits, the fruits of this plant we used for our study, they were removed and kept in Gomutra, that is a cow urine, for 7 days and then washed with water. The fruits were then shifted to a jute bag containing brick gravels and rubbed through and dried. This is the procedure for the purification, Shodhana process, which is given in the Ayurveda, which we followed for the purification processing of those plant material. Then all the plant material which we collected, they were subjected for the drying. As a morphological, as a standardization parameter, this is the morphological description. And the next part, as a core part of a standardization, that is a proximate analysis, which is also called as a physiochemical evaluation. So different parameters as per the WHO guidelines or the some Ayurvedic pharmacopoeias, these are the parameters which we need to follow to standardize particular that drug. So for all drugs, we analyze these parameters: moisture content, total ash, acid insoluble ash, water soluble, all these parameters, and all parameters were within the pharmacopoeial limits, means they were complying the pharmacopoeial limits. Then some extracts of those plants were prepared. This E for ethanol, M for methanol, water, this is a petroleum ether, C for chloroform, all the extracts were prepared and they were subjected for the phytochemical screening, and specifically for those secondary metabolites, they were checked whether they will be present, they are present in that particular extract. And based on those 4 drugs, we prepared our formulation. This is the composition of our formulation. This is a Balataka Semicarpus anacardium. Now you must have wondered why the name of this formulation is given as a Bhalatakadi Grita. Because This is one of the most active component of this Grita formulation, and the Sanskrit name of this drug is Bhalataka. That's why the name of formulation is given as a Bhalataka di Grita. So these are the 4 components derived from herbs, and kavu ghee, which is used as a base. That's why it is called as kavu ghee based preparation. That's why Grita. So we have used this clarified butter of cow milk. This is a flow chart for a preparation of Grita preparation. If you see the procedure, all plant parts were taken together. They were extracted with alcohol, mixed in equal proportion, equal quantity we took. If you see here, the equal proportion is mentioned there, quantity which is taken, 62.5, 62. All were in equal proportion. And the paste of this all extracts that was prepared, in Ayurveda it is called as a kalka. So in Grita, we have to take the composition in a particular ratio as per Ayurvedic text. That is 1:16:4. That is 1 part is a kalka, 16 part is a water, which is also called as a dravya, and kavu ghee, it is a 4 part. And by using that is a Grita Paka Kalpana, the process of a Grita making, it is called as a Grita Paka Kalpana. It was prepared and it was then filtered through muslin cloth, and whatever the formulation, Grita formulation which we got, it is, the name was given as Bhalataka di Grita, and the abbreviation is given as a PHBG formulation. In the next slide, you will be seeing the word PHBG. So just to try to understand, PHBG is nothing but a polyherbal Grita, Bhalataka di Grita. Then those formulation, that formulation was subjected for these parameters: organoleptic evaluation, phytochemical profiling, total phenolic, in vitro and in vivo biological evaluation, Ayurvedic processes, samskara, which are nothing but a murchana and shatadhota, and also the stability studies for that formulations were carried out. These are the organoleptic properties, that is color, odor, taste, appearance and touch sensation. As per the WHO guidelines of the pharmacopoeia, these are the parameters specifically for the fatty products of the Grita. So these were checked for our formulation: pH, viscosity, moisture content, specific gravity, refractive index. Whenever the fatty product is there, you have to go for acid value, saponification value, iodine value, peroxide value, Richard missile value and Polanski value. So all parameters were assessed for that formulations. And whatever the formulation we got, we subjected the formulation for in vitro antioxidant activity, that is by 3 methods: DPPH method, nitric oxide method, as well as hydrogen peroxide method. And kavu ghee has some antioxidant properties. So kavu ghee, which was compared with the PHBG formulation, our Grita formulation, and the standard, reference standard was taken ascorbic acid. So you can clearly see these are the IC50 values. The lower IC50 value is supposed to be better antioxidant activity. So even as compared to kavu ghee, that formulation, it was having a better activity, though it was not better than the ascorbic acid. Standard it was not, but it was comparable. Our main aim was, that is whether your activity is because of the ghee or of the herbs. So you can see it is synergistic effect, not only because of ghee, but ghee plus the herbs which we used. Then that formulation was subjected for accelerated stability study as well as the real-time stability study. Accelerated stability studies, which was carried out as per the, that is ICH guideline, 40 degrees Celsius plus 75% relative humidity, and real-time stability, that is 25 degree and 65% relative humidity. 25 degrees Celsius and 65% relative humidity. So again, in accelerated stability study, the same parameters which we checked initially, immediately after preparing the Gita formulations, they were stored up to 6 months for particular those conditions. And we checked for 0 month, 1 month, 3 month and 6 months. You can see here how the pH, all the parameters are deviated by the time. This was accelerated stability study. Now there is specific one formula based down by putting that particular data in that formulation. 30 minutes over. Okay, you can see here in that case, the formulation which we got, the shelf life of that product, it was a 2.4 years at accelerated stability study. In climatic zone 1 and 2, in climatic zone 3 and 4, it is 1.6. This is a real-time stability study which was carried out for 12 months. And again here, climatic zone for 1 and 2, 3.4 years, 2.2 years. That is the shelf life of our Greta formulations. The pharmacological evaluation which we subjected for wound healing activity, we prepared 3 different groups. Group 1 control, reference standard and test. Reference standard was taken as a povidone iodine ointment, and the test, which is our Greta formulation. And these parameters were checked, that is wound contraction, epithelialization time, percent wound contraction and hydroxyproline content. This is the excision wound area which we calculated. You can see from the picture, this is the control, on 15th day, the wound was as it is, whereas in case of test group, it was healed. Here also with the help of iodine, it was healed on the 15th day. This is the percent wound contraction. This is another parameter just to check that one, hydroxyproline content. Hydroxyproline content, it relates reepithelial generation of how your wound will heal fast, and that is determined based on the hydroxyproline content. This is the incision wound model. It was carried out by 2 excision wound as well as incision wound. Histopathological studies were carried out. You can see the normal skin. This is a control group. This is a reference standard, and this is a polyherbal, our test group. Now the main thing that is about those processes or the sanskaras. That is, these are the actual formulations. These are the images of our formulations which we prepared. This is a plain Palataka Grita. It is processed with a Murchana and it is with a Shatadhota. Murchana process, as I mentioned, there is an addition of 5 herbs, antioxidant herbs, specifically Terminalla cebula, Terminalla bellarica, Cypress rotundus, Curcuma longa, and Citrus medica. These 5 herbs were used, and the same Murchana ghee was prepared. Now, what was the benefit of this process? It removed bad odor and acidity. It maintained the ratio of unsaturated and saturated fatty acids and increases the stability of Greta formulation. The process of Shatadhuta, this I will just explain in short. Shatadhuta, 100 times washing means what? If you see the procedure, cow ghee, 2.5 kg, 1.5 liter distilled water you are taking. What exactly you are doing? You are triturating that cow ghee in water with agitator. After trituration, that water will allow to, that material will allow to settle and water will be decanted. And whatever the rest part, the settled part you will be getting, again you will be washing it with water, and that washing will continue till 100 times. So what is the benefit of 100 times of washing? That's why the word is there. Shata means 100, Dhahuta means washing. 100 times washing. What is the biological process in this? What is the science? Trituration. When you are triturating oil in Gita, ghee is nothing but a lipid formulation. That's why it is a W/O emulsion. When you are washing it, when the concentration, when you are adding more and more water, obviously the water concentration will be more. That's why there will be the phase inversion, and WO by emulsion, it will get converted to O by W emulsion. And 100 times washing, automatically it will lead to formation of a complex system, that is a W by O by W emulsion. And it will help, that is splitting of fat, unsaturated fat is hydrolyzed in the presence of water to yield free fatty acids and glycerol, which are removed with aqueous phase. So it will be completely fat free. And it will also change the pH to neutral side. So again, these are the procedures. The same formulation, PHBG2. This PHBG2 is the formulation which is prepared with Murchana process, and PHBG3, which is processed with a Shatadhuta process. So we compared all the formulation. First one, our formulation only, the formulation which is prepared with Murchana process, and formulation which is prepared with Shatadhuta process. And we compared these formulations. Again, there were some observation changes were there. I will just try to focus how you are getting the better results. Okay. Now, shelf life. If you see, this is the formulation which is prepared with Murchana process. In earlier case, the shelf life was 2.4 years, whereas it was enhanced up to 2.9 years. Here, in Shatadhuta process, the shelf life was increased up to 3.8 years. This is a real-time study. So I mean to say, Murchana process as well as Shatadutta process, it enhances the shape, it enhances the stability. Now when we come for the biological activity, how it will enhance? Again the same formulations, polyherbal Bharataka Grita as well as those processed with processes, Murchana and Shatadutta. Again we, last 2 slides sir. So we process the same, so you can see the difference. This is our formulation. Here the wound was healing on 15 days, but when the formulations were processed with Ayurvedic Samskara, Murchana and Shatadutta, the wound was completely healed on almost 12 days. And these are the last key findings. That is the novel formulation which we prepared. It was subjected for standardization also. We also validated those biological processes. We established wound healing potential of polyherbal Bharataka formulation with the help of wound contraction as well as hydroxypurin content and its wound breaking strength. And histopathology studies which clearly shows that is wound healing with a minimal inflammation and rapid tissue regeneration. Thank you, sir.
Well done, Dr. Sailendra Gaurav. It was a classical presentation. They told about the 5 elements of Panchakarma, 5 elements of Ayurveda. Panchabhumi. It's a very good presentation. We appreciate your involvement.
Thank you, sir.
Your dedication in giving this wonderful presentation for the benefit of our students.
Yes, sir.
Is there any questions from student side or for dignitary side? We can ask 1 or 2 questions.
I have a doubt, sir.
Please, ma'am.
How do you decide the process of shodhanas? Because there are many methods of shodhanas.
It is
and
based
you will
on
choose different methods for different plant species.
Yeah.
And how do you decide?
Ma'am, in case of a specifically that is a semicarpus anacardium, that process is already defined in Ayurveda only. We follow the Ayurvedic text. And in case of a rest of the process, in Ayurveda it is given. In case of leaves, stem parts, roots, what exactly you need to follow. All the process, we have not deviated a single processes from the Ayurvedic text.
You mean to say they are all these standardized methods of shodhanas?
Already it is given. Already it is given. But in case of Ayurveda formulation, what I perceived till my these studies, you cannot deviate by 1% also. If you try to publish those data in specifically Ayurveda in Integrative Medicine Journal, they will specifically ask you why you are deviating the Ayurveda process. Even you cannot change any one component also. Specifically Ayurvedic physicians, which they are preparing the new formulation. For example, Brahmi Grita is there. But at the same time, if we want to prepare another formulation by using some memory enhancer herbs, they will not prepare, ma'am. They will say, our Ayurvedic text, it is not given, so we cannot use. We can prepare. But other rest of the biological processes, Ayurvedic processes, we have to follow. That's it.
Thank you.
Thank you, ma'am.
Thank you, sir, for a wonderful session.
Sir, one question. Thanks for your wonderful session, sir. So this, whatever the scientific evidence you have generated, is it sufficient to take this for the further clinical studies and all? Like generating the clinical evidence?
This one you are talking. Of course, sir. I don't mind.
Yes.
In fact, we are planning the same thing.
Okay. Thank you, sir.
This is one of the doctoral students' research work.
And how about, sir, like if this evidence like is enough for only Indian market, I think, but is it, this data will be used?
Why only Indian market? It can be used by others also, no?
Okay.
Because most of the Ayurvedic products, they are used abroad also. So
Okay.
it is not community or the region based, not at all.
Okay, thank you, sir.
Any other question from student
Parle,
side?
sir. It's my pleasure to get the question from Parle, sir.
Thank you. I just have a simple question, for the society at large. Cow ghee is available in market and we all use it. You have carried out Shatadauta 100 times washing it to remove its unsaturated fats. But we are not doing it routinely, when we use cow ghee.
Yeah.
So does it contain so many unsaturated fats which could be harmful to the heart?
Of course, sir. It is there. It is there. That's why it is not advisable in a large quantity. In very small quantity it is advisable. And specifically, whatever the ghee which is available in the market, which is called as a desi cow. It is not desi cow, sir. That is the major problem. And all the study or all the Ayurvedic products, Ayurvedic Grita preparation, they are based on only desi cow. That is a Bos indicus. वो जर्सी गाय वगैरह जो मिलते हैं, it is not allowed. Those are the breeds, they are not allowed. And you will be not getting the results also.
Fine, thank you.
Any question from student side? If any question student not there, we will.
Yeah, good morning. Even animal ghees are also having the same lipid. As you said, lipisms. Every ghee should be same. What I feel. I mean, what cow ghee contains, which other animal ghee doesn't.
No, sir.
Contain.
No, sir. Actually, all the ghees are not same. Even the ghee which is prepared from sheep milk, even from donkey milk, also the ghee is prepared.
Yeah.
There are the several reports, research papers you can see. The composition is completely different, sir. Our desi cow ghee, it is always rich in carotenoids. That's why you can see the yellow color, golden yellow color. It is because of those carotenoids only. Even cow urine also. The other animals' urine is not advisable, but cow urine is advisable. Cow dung also, yes.
Yeah.
Yes.
What exactly that has other animals don't have that. So that's what I.
Yeah, the several research papers are there which are mentioned with compositions.
Okay.
Yeah.
Thank you, sir. Thank you.
Okay, thank you, sir. Any other questions? Our silent Gaurav Sahib is available with us. I can interact. Once again, we thank you on behalf of this
Thank
forum,
you so much.
Dr. Sailendra Gaurav, for your excellent presentation.
I thank the delegates for asking such meaningful questions. It brings us immense pleasure to have Dr. Shailendra Gaurav sir with us today. I request sir to kindly accept a small token of respect and I request our chairpersons to do the honor. Thank you, dignitaries. May I welcome Dr. Nilmal Singh Sir, Professor, Department of Pharmaceutical Sciences and Drug Research, Punjabi University, Patiala, for a talk on phosphodiesterase as an interesting drug target in dementia. I request a speaker of the session to kindly accept a seat on the dais, and I request our chairpersons to introduce to our gathering.
Very good morning, Dr. Nirmal Singh, Professor, Department of Pharmaceutical Sciences and Drug Research, Punjab University. Professor has 27 years of teaching, research and industrial experience. He has worked as principal investigator and also as co-investigator on various major research projects funded by CSIR, UGC, ICMR, DBT and DST. His research focus is on myocardial, cerebral ischemia, repression injury, memory, dementia and neuropathy. He has 270 publications for his credit with 18,200 citation and a H index of 61. He has authored 7 books and 16 book chapters, and he has 2 joint patents in his name. And he has also been awarded with 12 national and international best paper awards at various conferences. And he has also been awarded with Dr. S.C. Lahari Oration at IPSCON 2023, and he has been a reviewer for 35 international and national journals. Professor Dr. Nirmal Singh, we are proud and happy that you are here to address the August gathering here. I welcome you all on behalf of APSE and also on Sarada Vilas College of Pharmacy. And I hand over the session to you, sir.
Of the dais. First of all, I would like to say a big thank you to the organizers, Dr. Joshi, my friend in particular, for inviting me here and giving me a chance to deliver a talk. The topic that I have selected for today's talk is relatively, I think students will find it a little bit difficult, but anyways, some of the targets have to be discussed. We are talking about dementia right from yesterday. I think you are listening, what is dementia. Now, let me say something about the targets which are novel and are being explored for management of dementia. So I have selected this topic, phosphodiesterase as interesting target in dementia. So of course, up to now, you have come to know what is dementia. I will elaborate it, what my previous friends have mentioned about dementia. I'm just complementing or extending. You must have come across some of the incidents across us, which you see in our elder persons. It's very common. Most of us, I think all of us would come across this, that some person, elder person in the family, they starts forgetting some common things like name of the family members, routine things, common. So they start forgetting. This is incidence 1. Now that condition progresses to a situation where the person is unable to recognize the family member. The person is able to recall the episodes very long back, early, which happened very early in the life, like 50, 40 years back. But the person is not able to recall the things which just happened. So there is extreme memory loss, particularly short-term memory loss. And the person is not able to even recall that he has already taken a meal. So there is something, there are so many, you see reports in the literature that a patient of Alzheimer, he took 7 meals one after another, and still he was complaining that he is not being served the meal. So that is the situation. And then there is a third situation that's really serious, where the person is totally dependent upon the caregiver. There is extreme cognitive impairment. So this is what dementia progress is like. So dementia is a condition or a disorder which is characterized by progressive impairment of functional, cognitive and behavioral abilities. And primarily it is a disorder of elderly which involves loss of neurons in distinct brain areas. And cognitive and behavioral impairment poses a big challenge to the person suffering from dementia and the family and the caregivers. So if you look at prevalence, currently one of my young students friend, he mentioned that there is a current around 55 million cases. So this is a WHO report, I think 2017 report, which said there are over 47. Obviously there would be around 55 million, I agree. So number is projected to be more than 147 million cases by year 2050. In the US alone, there are around 4 million cases. I think in 2016, that number is projected to be double, up to 13 million by 2050. And India, that was a survey which was carried by Alzheimer's disease and related disorders Society of India. That was in 2010, the cases were around 4 million. That number is projected to be double by 2030. So this is the scenario and the prevalence of dementia. And amongst all dementia, Alzheimer is the most prominent or prevalent type of dementia. There are several different types of dementia. Anirudh has just mentioned various kinds of dementia, prominent 6 types of dementia he mentioned, but there are many types of dementias. Of course, the most prevalent one is Alzheimer. 60 to 70% cases belong to Alzheimer, followed by vascular dementia and other dementias. So Alzheimer is typically characterized by presence of extracellular deposits of beta amyloid, which we call as beta amyloid plaques, and intercellular formation of neuropeptide tangles, which are hyperphosphorylated tau proteins. There is a significant shrinkage of the brain. He showed the photographs that you could have seen. There is a complete shrinkage of brain mass and material in third grade of Alzheimer. So there is a brain atrophy and there is extensive loss of neurons, particularly cholinergic neurons in NPM area, that cholinergic neurons are positively correlated with the loss of memory in Alzheimer. So, in addition to beta amyloid and neuropeptide tangles, the other three important contributors to the pathophysiology of Alzheimer's are abnormal lipid metabolism, oxidative stress, and neuroinflammation. So if you look at the therapy, number of drugs are being used, but the US FDA has approved only two types of drugs, two categories of drugs, which are currently in clinical practice for management of dementia of Alzheimer. We do not have any drug for other dementia. The drugs which are approved for dementia of Alzheimer are used for other dementia management as well. So there are two categories only: the drug which try to improve the cholinergic neurotransmission by inhibiting acetylcholinesterase enzyme. Examples are donepezil, glantamine, and rivastigmine. And then we have NMDA. That girl told about excitotoxicity. So this NMDA receptor overactivation is involved in excitotoxicity and delayed neuron death, which is one of the primary cause. So this is one drug, memantin, which acts by inhibiting NMDA receptor. So none other than is so far approved. There are some monoclonal antibodies which are recently been approved by US FDA, but again they are targeting and their efficacy is still under investigation. So coming on to the targets, that is phosphodiesterases. Phosphodiesterase, first of all, discovered by Sutherland and co-workers somewhere in the late 50s and early 60s. Phosphodiesterase is basically enzymes which metabolizes secondary messengers, cyclic AMP and cyclic GMP. That is cyclic adenosine monophosphate and cyclic guanosine monophosphate. These are two secondary messengers which play important role in cell signaling. I think you are well aware of cyclic AMP and cyclic GMP. And these are very, very important molecules. PDSH, they constitute a large complex superfamily, and so far 11 gene families have been identified. Phosphodiester 4, 7, and 8, they are selective for cyclic AMP hydrolysis, whereas phosphodiester 5, 8, 6, and 9, they are selective for GMP, and the rest are non-selective, means they degrade or hydrolyze both cyclic AMP as well as cyclic GMP. So amongst all these families, phosphodiester 3, phosphodiester 4, and phosphodiester 5, they are extensively studied. So as such, phosphodiesterase can influence, because they play a critical role in regulating the intercell control of cyclic AMP and cyclic GMP. So PDA can influence number of pharmacological processes, including formation of inflammatory mediators, apoptosis, cell differentiation, smooth muscle contraction, and ion channel function, and so on. So many functions they regulate and influence. PD also play a role in cyclic AMP, PKA, and ERK signaling. This signaling is very, very important in memory processing. I like to let you know how cyclic GMP and cyclic AMP have a role in memory process. This process is very, very complex. Otherwise, I have made it very simplified. You just focus on cyclic AMP and cyclic GMP. They are downstream pathway through PK and PKG. They activate CREB. This is cyclic AMP response element binding proteins, and subsequently there is a gene expression, relevant gene expression and protein distribution leading to synaptic formation and synaptic plasticity. That is a mechanism, molecular mechanism, which has been described for memory formation. So in that way, cyclic AMP and cyclic GMP are important in memory processing and formation. So since PD, they regulate intercellular concentration, influence intercellular cyclic AMP, cyclic GMP, so in that way they can influence memory formation as well, and very, very important. Now, PD inhibitors as such, they comprise a large number of clinically useful drugs. Large number of PD inhibitors we are using in the clinical practice for various disorders, including heart failure, PDE3 inhibitors, millinone, I think would be knowing inodilators. Sildenafil, yet you know, used for erectile dysfunction. Then another condition in which they are useful in clinical conditions, that is COPD, that is respiratory disorder. Then they have also been found to be useful in various neurodegenerative conditions, and currently that's why they are referred to as a very hot target for dementia. Now these are some of the molecules, PDE inhibitors, which has shown efficacy in various conditions, neurodegenerative conditions, particularly they have shown their memory improving effect in various conditions. So I would like to highlight the findings of our studies with PDE inhibitors. We have done various studies with various different types of PDE inhibitors, PDE3, PDE4 and PDE. I'd just like to highlight some of the results of our studies with you. So this study with the selective PDE3 inhibitor, cilostazol, we studied the efficacy of cilostazol PDE3 inhibitor in rat model of streptozotocin diabetes-induced dementia. Diabetes, long-standing, poorly controlled diabetes is correlated with one of the risk factors for dementia. You can see the chances of dementia and diabetic is very high. So this is a kind of vascular dementia model that we have developed, and then we studied the efficacy of PDE3. We induced diabetes in rats with single dose of streptozotocin, that is 50 mg per kg, and we subjected these hyperglycemic rats to various behavioral, biochemical and histopathological after 8 weeks of streptozotocin injection. So we measured learning and memory of the animals by using Morris water maze test. This test is basically a swimming-based model where animal learn to escape on a hidden platform which is hidden in the surface of the water, and that escape latency to search out and escape on that hidden platform, that is noticed, taken as the index of memory, acquisition learning, and then on the 5th day, that platform is removed and animal is dropped down into the maze, and that time spent by the animal in that particular area, that particular target, that is noticed and taken as the index of retrieval. So what we found, in addition to those memory assessment, on water maze, we use brain homogeneity to carry out various biochemical estimation, including brain acetylcholinesterase activity, brain T-bar, brain GSS level, which is index of oxidative stress, then brain myeloperoxidase level, MPO level, which is index of inflammation. So here you can see the escape latency time was significantly increased in case of a streptozotocin group. Sorry, it is not coming. So anyways, so there was an enhancement in the escape latency time day for ELD, which was observed in STZ animals as compared to control animals, indicating impairment of learning. And the treatment of cilostazol in a dose-dependent manner decreased the escape latency time of streptozotocin rats. And in that way, they improve the learning. And this is effect on time spent in target quadrant, that is memory. Here you see the animals subjected to streptozotocin treatment, they showed a decrease in time spent in target quadrant as compared to control group. And the treatment of cilostazol significantly attenuated the decrease in TST induced by streptozotocin. So they improved the memory. So similarly, acetylcholinesterase activity was found to be very high in STZ treated rats, which was significantly decreased by treatment with cilostazol. We used donepezil as a standard control in the study. We also measured serum nitrate level. Serum nitrate level was measured as an index of endothelial dysfunction. It was found to be lowered in case of streptozotocin animals, and which was attenuated by treatment with cilostazol in a dose-dependent manner. Similarly, MPO activity was found to be very high in case of streptozotocin animals, which was significantly decreased by cilostazol treatment. So in conclusion, we see the administration of single dose of STZ produced memory impairment as indicated by poor Morris-Water performance, enhanced ACHE activity, brain oxidative stress, neuroinflammation, and leading to cognitive deficit. Silostazole inhibiting exerted its beneficial effect by its multiple mechanism by inhibiting all these alteration caused by streptozotocin. So this was a study with silostazole in diabetic rats. Then we carried out study with phosphodiesterase inhibitor, Rolipram, in various models. This is a study in mouse model of Alzheimer's disease. So we induced Alzheimer's disease. In the earlier study, we induced diabetes with streptozotocin. In this study, we are inducing Alzheimer with streptozotocin by injecting the subdiabetogenic dose, that we are not inducing diabetes. The dose was very small, directly into the brain intracerebroventricularly. So similar parameters we were carried out. Like we carried out Morris-Water performance, various biochemical estimation, and then H&E staining and conglomerate staining, particularly for visualizing beta amyloid aggregates. So again, we found significant increase in streptozotocin ELD, day 4 ELD, which was reduced by Rolipram. We also subjected aged mice as a natural model of dementia. So 4-day ELD was found to be significantly higher in aged as well as in streptozotocin mice. And Rolipram treatment significantly attenuated this rise in ELD in STZ as well as aged mice. So time spent in target was significantly higher in control group, which was decreased by, in case of streptozotocin and aged mice, and Rolipram treatment significantly attenuated this decrease in time spent in target quadrant and thereby improved Morris-Water performance. So in addition to time spent, we also subjected the rat to we visualize the rat, then track the video tracking. We track the pathway swim speed by subjecting using a software, Animaze. And we found that the path length was significantly decreased in case of control group, but it was high in STZ as well as in aged animal. Rolipram treatment significantly decreased the path length. However, there was no effect on swim speeds. This was, then the various biochemical alterations were also modified in case of streptozotocin and aged mice. And with this, streptozotocin and aged mice induced changes in various biochemical estimations like ACHE, T-bar, MPO, brain nitrogen level, and brain GSS. They were significantly altered in case of aged mice and STZ mice, and they were significantly attenuated by or ameliorated by treatment with Rolipram. So this you can see. So there were neutrophil infiltration, focal as well as diffused in histopathological staining, and this signify the inflammation and neurodegeneration. And then you see the conglomerate staining, you see the red deposits, red orange deposits in case of aged mice and streptozotocin treated animals. The Rolipram treatment produced a significant decrease in deposits of beta amyloid in conglomerate staining. So if you conclude this study, a single dose of STZ, subdiabetogenic dose injected intracerebroventricularly, produced memory impairment, that is decreased the Morris-Water performance, other biochemical alterations, and along with there was a beta amyloid deposition that was observed in conglomerate staining, leading to neurodegeneration and cognitive deficits, which were ameliorated by treatment with Rolipram. So this was study in Alzheimer's disease. We also carried out a study of Rolipram in another model, that is in vascular dementia induced by sodium arsenite. So here sodium arsenite solution was used, freshly prepared solution was used and given to the animals for 45 days, and the treatment was started from 41st day onwards, and we observed the various parameters. So along with the Morris-Water study, we also carried out endothelial dysfunction by using aortic strip, and where we measured the endothelial dependent and independent relaxation, and we also carried out various biochemical estimations. So again, we see there was a significant increase in the day 4 ELD, which was significantly attenuated by Rolipram. And we see the time spent in target quantity was decreased in streptozotocin, sodium arsenite rats, which were reversed by treatment with Rolipram. So this was endothelium-dependent relaxation, which was decreased in case of sodium arsenite, and treatment of Rolipram attenuated this decrease in endothelium-dependent relaxation induced by sodium arsenite. So the nitrate level was also down in case of sodium arsenite, which was improved by treatment with Rolipram. So this is ACHE activity, which was very high. That was also improved by treatment with Rolipram. Then this is myeloperoxidase activity, which was also very high, and this was also reduced by or improved by treatment with Rolipram. So similar in case of T-bar, the activity of T-bar was decreased, level of T-bar significantly improved by treatment with Rolipram. Glutathione level was decreased in sodium arsenite animals, which was improved by or increased by treatment with Rolipram. So here we see sodium arsenite solution lead to impairment of memory, endothelial dysfunction, that is along with this endothelium-dependent relaxation, and there was a decrease in the serum nitrate level, enhanced the ACHE activity along with the neuroinflammation, leading to vascular endothelial dysfunction and dementia, and this it was improved by Rolipram treatment, the PDE4 inhibitor. Now we also carry forward study with the PDE5 inhibitors. In fact, we started working on PDE5 inhibitors very early. We carried a very basic study with sildenafil. Parle sir is sitting there. My first paper was published on sildenafil, PhD. The sildenafil, that was a very hot time at that time. It was just launched for erectile dysfunction, and we just carried a basic study. I'll let you know what was that study, but let me tell you about tadalafil, which we carried out in different animal models. We studied the tadalafil efficacy in vascular dementia, which was induced by hyperhomocystinemia, another different model. So we induced hyperhomocystinemia by administration of methionine. We daily administer the methionine up to 56 days, that is up to 8 weeks. And drug treatment was started from 30 days onward, and the Morris-Water maze estimation were carried between 52 to 56, and afterwards the animal were subjected to various, they were sacrificed, and borine homogeneous were isolated, blood samples were isolated, and they were extracted, and they were subject to various kind of estimations. So this was the protocol. That was methionine, vascular dementia. We also studied the efficacy of tadalafil in streptozotocin diabetes-induced model. So we used two different models for studying efficacy of tadalafil in vascular dementia, what was in hyperhomocystinemia, and that next is diabetes-induced. So here we induced diabetes with the single dose, as I mentioned in my earlier study, 50 mg per kg IP, and we subjected the rat to various behavioral and biochemical histopathological estimation after 56 days. Protocol was almost saying we started the drug medicine from 30th day onwards. So that was the paper which I was talking about. So this was the study, very early study we carried out in 2003. And very basic study, we used benzodiazepine-induced model of amnesia, where we study the anti-amnestic effect of sildenafil, and we found very good results that time. But because my study was not only on sildenafil, so somehow I stopped working on sildenafil and PDO, but later on I found this target very, very encouraging. So I continued study with various PD inhibitors. So because PD3 and PD4, they are well known and are in the market. So we started with PD3. Now we are continuing, and what we studied in tadalafil are again same estimations we carried out. Behavioral estimations, that is memory testing on Morris-Water maze, endothelial dysfunction by using isolated aortic strip of rats, and we studied the endothelium-dependent and independent relaxation. And we also estimated serum nitrate level as another biomarker of endothelial dysfunction, and various biochemical estimation along with histopathological studies. And what we finally found that PDE5 inhibitor tadalafil in all models, that is hyperhomocysteine-induced vascular dementia and diabetes-induced vascular dementia, improved Morris water maze performance, which was decreased by hyperhomocysteinemia and your diabetes, improved endothelial dysfunction by improving the endothelium-dependent relaxation and increasing the level of serum nitrate. Then there was a significant fall in brain ACHE activity that indicating cholinergic neurotransmission improvement, decrease in the T-bar level and increase in the brain GSH level, improved oxidative, that is decrease the oxidative stress, and there was a fall in brain MPO activity indicating improvement of neuroinflammation as well, and of course neutrophil count in HE staining, again indicating decrease in inflammation. So I would like to conclude with the next two slides. So here methionine, that is hyperhomocysteinemia, and cephalosporin, that is diabetes, led to memory impairment, decrease in the serum nitrate level along with the endothelial dependent relaxation indicating endothelial dysfunction, increase ACHE activity and other parameter of neuroinflammation, leading to vascular endothelial dysfunction and associated dementia. And the treatment of tadalafil improved the hyperhomocysteinemia-induced and cephalosporin diabetes-induced vascular dementia. So, one thing is clear that overactivation or excess of phosphodiesterase is the deleterious, and it initiates a deleterious cascade that ultimately lead to cognitive impairment. Here you can see overactivated phosphodiesterase can lower down the cyclic AMP and cyclic GMP, and the cyclic AMP and GMP pathway will lead to the cascade which is deleterious, and ultimately there is a deposition of amyloid beta, inflammation, neuronal damage, and there is a cognitive impairment. And that phosphodiesterase inhibitors, they, by inhibiting the phosphodiesterase enzyme overactivity in the brain, will be very useful for improving this deleterious stage and enhancing the, or improving the memory in dementia. So in conclusion, as I mentioned, inhibition of phosphodiesterase that are overexpressed in the brain is beneficial for the management of dementia, of Alzheimer and other etiologies. And of course, PDEs are interesting drug target for memory disorders. And there is a need to bridge the translational gap between preclinical and clinical study. That is really the need of the hour. Of course, there are 3-4 molecules, PDE4 inhibitor roflumilast, and another is PDE9 inhibitor that is in clinical trial, that is in phase 3 clinical trial. So that is the latest information. So I would like to extend my thanks to my department and my lab and my all doctoral and research students. So thank you very much for your patience listening. Thank you. Thank you, sir.
Excellent presentation, sir, Dr. Nirmal Singh sir, about the various role of this enzyme, PDE, all this information given. You have done one good thing I observed here. Your presentation ignited one of the students here, PharmD student. Who is that student who has given oral presentation? It has been an inspiration for the young student to go ahead for the research. Is the student is here now? One student was giving oral presentation about this oxidative stress and dementia. In the morning season I could see there are some student, PharmD student.
Listen their lecture and they were giving very good information.
Very information. We appreciate you, sir, on behalf of the entire conference, the elaborative information about this PDE enzymes and its roles and applications. So with this appreciate you, sir, and our colleague.
Thank you, sir.
Thank you for that wonderful presentation, sir. And hope these inhibitors of PDEs play a major role in combating dementia, because as said by you and as we are all aware of, the patients suffering from dementia or Alzheimer's is increasing, and we have to seriously think of combating with that. Thank you very much for that.
Thank you, ma'am. Thank you so much.
Presentation. And the session is open for interaction.
Thank you very much for the wonderful session, sir. So, as to PDE5 inhibitor like tadalafil, already approved for 2 to 3 indications. So, like for dementia, like whether directly can we go for like just efficient, like drug repositioning studies?
It is approved for another, it is under clinical trial. PDE inhibitors are indeed under clinical trial.
Yes.
But I think they are at present they are at level 2.
Okay. Yes.
So only roflumilast I mentioned, and there is another number compound that is PDE9A inhibitor that has entered into phase 3.
Okay. Okay. Thank you, sir.
Thank you, sir.
Sir, Nirmal sir, I have one question. And in the beginning slides, you told that streptozotocin induced vascular dementia, and you have evaluated the drug activity after 8 weeks. Why it is 8 weeks? Less than 8 weeks or more than 8 weeks?
So I mentioned about vascular dementia. Vascular changes, it takes time to happen actually. It is a very clinically relevant. So even early diabetics, they don't show any sign of dementia. Only late diabetics, poorly controlled diabetics. So it is quite a clinically relevant model. And in case of Alzheimer dementia, which is diabetes independent, that we use model 0.3 mg where we injected, that in that case we could able to see the memory loss after 15 days. But here you see endothelial dysfunction that appear only after 4 weeks of streptozotocin administration, and then subsequent dementia that we see that appear near about 6 to 8 weeks. So we have standardized this model 8 weeks.
Thank you. Thank you.
Any other questions from the audience or for dignitaries? If no question is there, our Nirmal sir is available.
Good morning,
here.
sir. So it is not at all useful in the to dissolve this amyloid, and what we have say that it is only it is in the what we call as an inflammation, because it is going to produce that inflammatory mediators such as IL-12, IL-18 and TNF alpha. So whether the drug is perfectly or a repurposing drug, we are having this plenty of drugs that is a PDE1.
Yeah, we have.
Just like
I mentioned vinpocetine.
that's what, sir. That's what there is a pentoxifylline.
Yes.
It's almost all this 30 years old drug. So we are using for this even PDE1 also.
So that is their studies are going on for repurposing. And of course, I mentioned that PD is a big family. And now PD9A, what I mentioned, I have not carried out study the PD9A, but it is there, and you see ample reports about PD9A, and it is in clinical trial currently. And of course, vinpocetine and other PD1 inhibitor, because they are actually less studied families. I focused on PD3, PD4, PD5, but there are other families now which are emerging. A lot of studies are being carried out now. PD1, vinpocetine is one of them. And of course, curcumin, curcumin is also having a PD inhibitory activity. That is very, very interesting.
And it is
curcumin.
Having, that's what, and it is having nothing to do with the amyloids.
As such, we are not symbolizing anything.
There is no.
We are carrying out simply experimental studies on animals.
That's what. So we won't say only neuroinflammation.
Of course, I have mentioned only MPO. Of course, what are the cytokines you have mentioned? They are very specific markers of inflammation. And you will find number of studies where they have studied these cytokines. Although we have not studied, but other studies they have reported this.
Because sir, when we are going for this amyloidosis, it's an amyloid, particularly this structure 2, that is a secondary, which is responsible for the amyloid, where this PDE5 or either any this PD family is nothing to do with this amyloid. Only we are focusing on this inflammation.
Target based inflammation. You are focusing on inflammation. Inflammation is one of the primary, marker or parameter which contribute to dementia and other neurodegenerative disorders.
Dr. Sir.
Thank you, sir.
Thank you.
Thank you, Dr. Nirmal Singh, for giving information to the audience, questions as well. And with this, we like to once again appreciate our Dr. Nirmal Singh for his excellent presentation.
Sir, in addition to yours, I would like to just enter into nanomedicines nowadays being called for, and where exactly this going to disrupt these amyloids, and probably at the lower scale level that is never going to produce much side effects. Safety and efficacy and longevity is very important, because all the patient is in the deathbed and is is just pulling on his life, and is very difficult to tolerate. And at this condition, safety and efficacy is not going to be the one. The important is going to at the what level it is going to disrupt the anti-dementia.
Of course, nanomedicines, they are basically target specific medicines and which are being focused on and being discovered. And definitely the question of safety and efficacy will always be there, and we have to look into this aspect as well. And we have to balance or assess the risk and benefit ratio that is there for every medicine that we have to look into. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you very much.
Thank you for sharing your wisdom through your talk, sir. And I thank the delegates for asking such meaningful questions. It's an honor to have Dr. Nirmal Singh, sir, with us today. I request, sir, to kindly accept a small token of respect. May I request our chairpersons to hand over the memento to our speaker. Thank you, dignitaries. I'd like to extend my gratitude to Professor Dr. A.K. Gnanachandran, sir, and Dr. Devika, ma'am, for chairing the session. I request Dr. Maitreyi, ma'am, and Dr. Milind Parle, sir, to hand over the memento and honor our chairpersons. Thank you, dignitaries. Refreshments has been arranged outside. I request the gathering to accept the same and be back here within 15 minutes. I repeat, refreshments has been arranged outside. I request the gathering to have the same and gather back in the auditorium within 15 minutes. Thank you.
ಹಲೋ 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 ಬರ್ತಾ ಇದೆಯಾ? ಕುಮಾರಣ್ಣ ಮ್ಯೂಟ್ ಮಾಡಿದ್ದೀರಾ? ಏನ? Hello. 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 Hello, sir. Hello. Hello, sir. You are audible, sir. Okay. Okay. So let me
So you
know
give me those.
when.
Sound. ಕುಮಾರಣ್ಣ ಸ್ವಲ್ಪ ಸೌಂಡ್ ಕೊಡಿ.
Hello, sir. Good afternoon, sir. I'm Dr. Jinesh.
Good afternoon, sir. Hope I am audible.
Yeah, you are audible, sir. You are audible. Your screen is
And
also visible.
yeah, my presentation is visible to you all.
Yes.
So I'll
Just
make it in.
sir, we'll call persons on the dais.
Okay.
Then we'll start. 2 minutes.
Welcome back everyone. I welcome Dr. Kiran Kumar Hulleti sir, Professor and Principal, Sarada College of Pharmacy, Belagavi, and Dr. Gururaj sir, HOD, Department of Chemistry, Sarada Vilas College, Mysuru, to chair the session. May I now welcome Dr. Banappa S. Ungar sir, Scientist E, Head, Pharmacology and Toxicology, ICMR, NITM, Belagavi, for a talk on zebrafish as a model of metabolic disorders for herbal drug research and development. I request our speaker to kindly occupy a seat on the dais. So will be presenting on. Hello.
Audible?
Are we audible?
Hello. Hello.
Yes, yes, ma'am. So let
So
me know
we'll be
once.
presenting the. Hello.
Shall I proceed?
Yes, please, sir. You proceed, sir.
Hello.
Yes, sir.
Sir, you can start, sir.
Yes, yes. Thank you, sir. Thank you very much. Yeah. At the outset, now I would like to thank our Honorable the President of APSE and the dynamic the Secretary Dr. Hanumantachar Joshi for giving me this opportunity to join online. I seek pardon from all the
Just a
organizing
minute,
team
sir.
that
Hello.
I for this inconvenience caused due to this online presentation. It was
Sir, just a
unavailable
minute.
out of
Hello.
the station.
Hello, sir. Just a minute.
Yes, sir.
Yeah, the chairpersons will introduce you, sir. Just a minute.
Okay, okay, sir. Okay.
Hello. Hello.
ಅವ್ರಿಗೆ ಮೈಕ್ ಕೊಡಿ ಹೋಗಿ ತೇಜಸ್ವಿನಿ.
Hello.
I request the chairpersons to kindly introduce our speaker to the gathering.
Good afternoon, everyone. Today we have Dr. Banappa S. Ungar, Scientist E, Head Pharmacology and Toxicology, Indian Council of Medical Research, National Institute of Traditional Medicine, ICMR, NITM, Belagavi. He has got experience as Scientist E from ICMR, NITM, Belagavi, and along with before that one, 27 years in teaching, research as well as in industry. His research articles on animal models of inflammation, laboratory surveillance for SARS-CoV-2, aloin alleviates doxorubicin-induced cardiotoxicity, immunomodulation of type 2 diabetes publications. So totally he has got research articles of more than 270. He has got some awards and achievements. Best Paper Award at 12 National and International Conference, Nodal Officer for ICMR COVID-19 Testing Laboratory, Member of Institutional Ethics Committee and various professional societies. With this brief biodata, I welcome Dr. Banappa Unger, is a very close friend of mine, to deliver his talk.
Thank you, sir. Thank you very much. Again, good afternoon to everyone here, both online and offline. Once again, I would like to thank the chairman person of this session also, and the chairman of the APSE and our dynamic secretary, Dr. Hanumantaras Joshi, for leading this wonderful the committee or the association in these scientific endeavors. So I would like to begin my talk on the zebrafish as a model of a metabolic disorder for herbal drug research and development. So as you all know that the two terminologies here are the buzzwords now I can say, and the third one, the zebrafish also having the same intensity nowadays. What are those buzzwords? The metabolic disorders are one of the the impending epidemic, we can say, and it is a very big problem in these Asian countries specifically also, and throughout the globe. And the other one is the herbal drug R&D. So herbal drug has a lot of potential to become a new drug also with the effort of R&D to develop them as an novel molecules also. So in addition, in between, to join these disease and the drug, that to get developed as a drug, we need a model organism, and there this zebrafish comes one of the promising, or you can say the very popular nowadays, a model organism to screen toxicity as well as for the screening of the drugs for various diseases. So what is this? First of all, it is a diploid minnow. It belongs to the family Teloes. And more importantly, that no, it is not new to us. In fact, it is an indigenous to India, which originated from the Ganga River, and it was taken by the Western world for the scientific research, and it was established as one of the model for the studies. 1970s. So you can see here that why this has become a popular model. From the 1970s, it started its journey, and now for the various biological activities, both in developmental biology and disease biology, as well as for the pharmacology and toxicological studies. Nowadays, it is a preferred model, I can say. So here you have a picture on the right side in that the animals swimming in the tank, and in the left side you can see the female and the male zebrafish, how they look and how to identify. These are the some general questions which are asked by many students. Yeah, first I would like to emphasize that this presentation, when have decided to deliver here, the intention is that now APSE is working on education and the research. And this presentation is focused on the majorly on the student community and young researchers like me, and I still consider young, although I have now grown with these years. So coming to these unique advantages are excuse me. Hello? Hello? Yes? Okay. 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 Yeah. Sorry for the disturbance. Hope it is audible clearly. Now, the echo is from not my side actually. There is from host, I hope. Uh, Dr. Hullati, sir, if you have a mobile, something from there, I hope it is getting echoed. Or that mic has to be switched off, sir. Yes. Yeah. So I would like to highlight this model organism which I am using. I was fond of this model organism since 2012. Hello. Okay. Okay. Yeah. Coming back to this, it's a unique. The features or similarities with the humans, which makes this model organism very suitable for our studies. So I have mentioned here that and with the pictorial also there is a representation representing it similarity with the human anatomy and physiology. You can see that color coded one, the red one, the line shows the heart and the circulatory system, and the green that's the brain and the nervous system. So in addition, there are other organs also which are visible or color coded here. You can see that the genetically it has got 84% of disease relevant genes which shares with the humans. So any organism having this kind of similarity is sufficient to be a good model for the pharmacological studies. Anatomically also that now we should have that organ which is of our interest. For example, if I am studying diabetes or the metabolic disorder, it should have a pancreas, adipose tissue, skeletal muscle, liver. These are major organs which are involved in this the physiology, pathology of this particular disease. So in the similar way, if we have a cardiovascular symptom diseases to study, it should have a similar the electrophysiology. If it is anatomically similar, that is better. But here in this case, it is not anatomically similar because it has got a two-chambered heart. But still, the physiology is more similar to that of the other model organisms when you compare with the humans. So that's how the various the physiological systems, as I mentioned, that CVS, CNS, not only that, even the endocrine signaling mechanism and immune response also, the very important component. At the early stages of its life, it does not have an acquired immunity. So if you want to study the innate immunity component, you have an advantage that you can use these larval stage animals to study without interference of an acquired immunity. If you want to have these both the acquired and the innate immunity components together, then we have to wait for its development for certain duration. So that is why the many people across the globe, they have used this model organism. The lot of models now been published, like diet induced obesity model. Even our own publication is also there on the drug induced obesity, and there are several other models like streptozotocin induced model, as well as high fat diet with streptozotocin, that is representing the type 2 diabetes. So in addition that cancer, both the chemical induced as well as that the what you call xenografting is also can be done, and you can suppress the immunity. That's when you compare with that, no, these kind of studies in the rodents, it is very difficult because you have to have immunocompromised animals, and maintaining that immunocompromised animals is also difficult. But in case of this zebrafish, having this no immunocompromising the protocol is also very easy, and we can have a the people already have demonstrated the good ability of having the cancer models through the xenografting, taken the the cancer tissues taken from the patients. So in addition, there are other models, CNS disorder models also, like anxiety, depression, epilepsy, whatnot. Now they can I can go on listing them. Most of the diseases now can be modeled in this, and they are using, including the infectious diseases like the cholera, tuberculosis, and other infectious diseases also. So that is why this is a one of the preferred model for the pharmacological and toxicological studies. So as I mentioned, there are several unique advantages, and particularly when you come to the drug discovery and development as a tool, it should provide an economical option, both in terms of our economy means not only about the fund or the money involved, even our time and the compound test compounds which are required to test this kind of activity. So because of its high fecundity rate, or you can see say that no, with a pair of the zebra fish, you can get 100, 200, 300 embryos in a day. So getting these the rodent models or the rat and mice at this speed, it is definitely not possible. So this is the one advantage, and as it is not depend, I mean the mating is not dependent on seasonal. The supply of animal is not going to interrupt. If you are maintaining the conditions properly, you can get the animals throughout the year. So the maintenance cost is also the considerably low, but it is not completely nil, because we have some maintenance to be done with this when you rear or breed these animals and experiment with these model organisms. So another advantage or a disadvantage, you can say, sometime it is a disadvantage because it's very small. So handling and getting these drug injected or the organ isolation, these are all a little bit of tricky issues, but it's an advantage also in other way, because of the small size of these embryos and larvas. The embryos and larvas which I shown in that the first slide, which is just a maximum of 1 to 3 mm size. So with this millimeter size, you can put them into an multi-well plates, and you can handle easily in terms of its maintenance, as well as the compound requirement and other things. So because of that, it is also possible to do an high throughput assay. At a time, you can run a 96 animal study. It is very difficult to do that same thing in the other model organisms. That's how the comparatively it is economical in terms of money, time, as well as the test compound requirement. And another advantage is fast development. Again, I consider it as an advantage. Sometimes it is a disadvantage also, because within 3 days, whole the body plan gets developed, and it's so fast that you have to catch your endpoints very sharply, because otherwise you will miss that. It's like the train fly, I mean running at a speed of 100 kilometers per hour, and you have to catch it immediately. So that's how it's very tricky also, but it is advantage also, because many no lengthy studies can be completed in a very short duration of the time. So that is why it is economical, and round the year you can have the supply of animals, and test compound requirement is also less, and the time required to do the studies will be very less. So those are the unique advantages of this zebrafish. That is definitely will be now welcoming points by the researchers. So I was saying that no, this is our paper published in long back actually in the Journal of Future Journal of Pharmaceutical Sciences. So where what we did is that now earlier we saw that now metabolic abnormalities in humans that was modeled in rats earlier by us, and it was reported published in the Journal of European Journal of Pharmacology in 2006. So that was the stimuli, or you can say the motivation that no, can we do the same kind of that the development of a model, drug-induced obesity model in these small animals. It will be further advantageous. With that objective, we have done this study and published it. So what we did here is that now with the exposure of olanzapine, olanzapine is an antipsychotic drug, atypical antipsychotic drug. It has a very good antipsychotic activity, but the major disadvantage with this is the metabolic abnormalities, which is the major problem. So what it does with this when you expose it to the animals is it decreases the lipid metabolism. So there will be accumulation of the fat, and how it decreases? It decreases through the decreased metabolic rate. So these are the important the parameters which we have measured in this model organism when we have exposed it to the olanzapine. So, as I mentioned, the olanzapine is associated with many adverse effects. That's the major one is a metabolic one. That's what we have did that demonstration of that in this model. And the various pathways also through the in silico tools, we have studied that now what are the pathways, whether the pathways which are involved in these are similar to that of other model organism and humans are not. That also we have come from, and it is there are 7 metabolic pathways, and the lower panel of the denier area you can see that. So those are the genetic pathways which are involved in the metabolic abnormalities caused by the olanzapine. So in addition, what we have measured is the lipid accumulation. That now you can see here in the right panel, these are the embryos of 3 to 7 days old when we started treating with that high fat diet and or sorry, in this case it is a olanzapine. So there is an accumulation of fat. You can see the intensity and the integrated density was calculated. You can see when you have exposed 25 micromolar of olanzapine, there is an significant increase in the fat accumulation that was represented by the color intensity. The color is nothing but your yellow red stain. Yellow red stain is an specific to the neutral lipids. This gets stained. So it is an surrogate marker of the quantity of the lipid which is stored in the liver. So that's how we can see the changes when you compare with the control, solvent control as well as the other dilution controls. You can see increase in the dose of the olanzapine has increased up to 25 millimolar. There is an increase in the fat accumulations. So as I mentioned, the one parameter is fat accumulation. Another is how this fat is not metabolized. Why it is getting accumulated is because of the decrease in the metabolic rate. How you can measure that? A very simple assay of that color phenol red we have used, but now it is having some disadvantages. There are other modified methods are also available, like fluorescent dye is now being used. That also I'll explain you. So here what we done is that with the phenol red indicator, it gets color change, and that can be easily measured with the spectrophotometer or any device or any plate readers you can use. So in this case, we have used the plate reader, ELISA plate reader, and I have seen that how much change happened with the olanzapine treatment. You can see that the lower panel, there is a significant increase in the olanzapine treated animals in terms of the metabolic rate. So I was mentioning that another method of measuring metabolic rate, that is when you take the resozurin, this get converted into resofurin when there is a production of NADH. That is a byproduct of our metabolic activities. So that is also a very clear indicator and sensitive method also that can be measured by using the multi-mode fluorescent reader. If you don't have the fluorescent reader, you can go with this spectroscopic
You have
or
5
the
minutes.
absorption by UV also with these methods.
Excuse me, sir. You have 5 minutes, sir.
So that's how they can use
On next
the various drugs. Both the food and the drug can be used to induce the metabolic abnormality. This slide, it shows our the zebrafish facility in our institute. So we are using it for toxicity studies and as well as for testing the botanicals or the herbal drugs for their pharmacological activities and also training and capacity building programs. So in this panel, you can see here in the center, there is an adult zebrafish. So it is nothing to do with zebra, but just have the stripes. So it is called as zebra. It is a fish. And you can see at the lower right panel in the this one, you can see the embryos. The embryos are translucent. You can see that Korean, which is translucent, so that developing embryos can be observed with the stereo zoom microscope. And in the left panel, you can see this the larva, where even if I am able to run some of these videos, I will run and I'll show it to you. So with the um, this zebrafish model as a model, we are using it for
Excuse me, sir.
various
You have
purposes
5
like
minutes.
including the NASH, which is also a metabolic disorder where the fat accumulation and also the inflammatory changes in the liver, that is one of the biggest problem. And there are several claims from the herbal drugs. Here we have tested Terminalia cebula extract and fractions, and we using the same like the fat accumulation by using ilored stain method, quantifying it, and also the metabolic rate assay by the resozurin fluorescence assays. In addition, we are also trying to correlate with the in silico tools, that is network pharmacology, to understand how they are causing or this intended or unintended effects. So, hello. Yes. Okay. So this is a one more study on Garcinia indica. That's also here. You can see the even adult zebrafish can be used here. That high fat diet induced obesity in zebrafish we have performed with the help of this adult zebrafish, and you can use this metabolic rate assay also here. So you can put the zebrafish in falcon tubes, and you can collect that the system water at the different time intervals to measure the metabolic rate. That liquid can be used for staining, for the metabolic rate assay by resozurin absorbance or fluorescence. So this is an hepatotoxicity assay. With this, I end, and if there are any questions, I'm happy to take it. Thank you once again.
The pharmacy.
Hello. Am I sorry? I'm unable to hear you. Hello. Hello. Yeah, now I can hear. But the question I am unable to hear by the chairperson. Hello. I'm unable to hear. Just you can unmute that Joshi's this mic is muted. I mean, chairperson's.
Hello, 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 hello.
Yeah, now I can hear. Again, it is muted. Okay. Hello, sir. Sir. Yes, sir. Yes, sir. Yes. Thank you, ma'am. Yeah. Yes. Okay. Your call disconnected. Sorry. Hello. Hello, madam. Call disconnected, please. Yeah. Ah, okay. Uh-huh. Okay. Okay. Yeah, madam, actually that no, we have done the larval models and we have not actually observed those, recorded those changes. Possibly this might be happening. I don't know. We have not recorded it.
support for the pharmaceutical development and 7 years in Chinese pharmaceutical industry with experience in regulatory audits from US FDA, UK, MHRA, TGA and CFDA. And he is a recipient of many awards. One famous award is Ananjo Friendship Award in the year 2020, and he has recognized again another award also he received as a recognition award in the year 2019. And his area of research is analytical research and development, pharmaceutical products including IND and NDA, and generics for global markets, US, China, Australia and RO. So indeed it is a very happy moment, Anil Randev. So he has accepted our invitation, and this one he is going to give the talk on, that is again digital innovation. And this particular topic is, I think it is most vital in pharmacology, what I feel. So very good topic you have selected, and I think you share your knowledge on the behalf of APSECON and Sarada Vilas College of Pharmacy. I welcome for you for this session. Now the session is for you.
A very good afternoon to all the dignitaries on the dais and off the dais, and my fellow pharmacists and my dear students. So without wasting much time, I will directly jump into the presentation, because it's very hard to cover the topic AI-driven drug discovery in 30 minutes, but I will try my best to convey at least the brief about this topic. So Cyber AIDD, it's a ready-to-use tool for AI-driven early-phase drug discovery. So it improves the or boosts the efficiency in drug target exploration and also molecular design. So I think we are hearing a lot about the, AI's influence in each sector of the healthcare as well as even in the pharma, like early phase, even in the preclinical and the toxicity prediction and like clinical prediction also. Now the tools are, work is going on to bring up some AI tools. So I am focusing today on the Cyber AID, which is a tool for early phase drug discovery. So the topic I will be keeping in three subdivisions. Like the favorite question of any scientist is if any new tool or any new invention, it starts with the question why. So here also, why Cyber AID or why any AI driven tool for pharmaceutical research, and how it works. The second question is how it works, and third is we'll see some tool features, followed by some advantages of using the innovative tools in our routine research work, followed by we will also see how these tools can be adopted to the academic research. So coming to the question why, so we see that like a lot of Indian or Asian countries, we never take up the new drug discovery projects. It is because any new drug discovery project takes long like development cycle, and it costs a lot, and the success rate is just 5%. So no like small or medium sized companies want to take this risk. So what is the solution for that? So now the companies are shifting towards the like business models are shifting towards the cooperation with and channel diversification. They are collaborating with the AI companies. Pharma companies are collaborating with the AI companies, or even academic institutions are collaborating with the digital companies, so that they can save time and resources and bring up the new drug in short time with less resource. So this is one thing is happening in the pharma industry. And this is example, like the number, you can see the number of cooperation between the international leading pharma companies and AI companies. With even the deal size is mentioned here. So you can see the Roche's collaborated Recursion is a AI company. And even like AstraZeneca with Benevolent AI. So this is what, how the trend is moving. So that another answer for the question why, like using the digital innovation tools like, or AI tools can reduce the timeline for the drug discovery, especially if it is taking 5 to 6 years for the traditional early phase drug discovery, it can come up to like less than 2-3 years. Recently, there is a company called In Silico Medicine, which has brought a clinical candidate in just 18 months. So this is the power of digital tools, you can say. So these are some examples of the AI companies. These AI companies don't have their lab. They just have the tool in their hand and they have brought their assets and which are already in the clinical phases. So I think next 1 or 2 years, you will be seeing the AI discovered drugs in the market. So, and this is not a, like even it can happen in our university level also because these are just the tools which with just a laptop or desktop computer and with the web-based applications, even any student or faculty can use and bring up their own assets and get it patented and we can sell it to any pharma or companies, big pharma companies. So here is one more example I am showing, like there is an, compared with the clinically developed GLP-1R oral small molecule agonist danuglipron, the compound designed by AI company. So this is patented, world patent. So they have showed significantly improved pharmacokinetic properties. So this is like, they have the data of all the molecules which are under either in the preclinical or clinical stage or in the market. So based on that data, the AI models are predicting a better molecule for you. Either improved efficiency or improved pharmacokinetic properties or improved drugability properties. So just now like we have seen why any digital innovation tool or why AI driven drug discovery tools to be adopted. So coming to how it works. So Cyber AIDD has a built-in on AI principles. So AI principle is very simple. We have a data as a backbone for AI models to consider, and these AI models will predict something for us. I think everybody might be using the chat GPT. So there is a lot of content available or data available already, and there are models which will predict based on the existing model. So this is a simple, very simple principle of any AI tool. So, and already I think many colleges or chemists might be using computer-aided drug design tools. So these CIDD platforms offer powerful molecular modeling capabilities, and they are like BioVia Discovery or Schrodinger. They emphasize on molecular modeling, including docking simulations, and principles involved here is like physics-based, like free energy changes. But our in AI models, like advanced machine even in the CIDD, computer-aided drug design, there is a part of AI is used, but that is just to like supporting role. AI will play a supporting role. But in AIDD tools, AI is the principal, like main principle of prediction. So this is what about just to differentiate how CIDD is different from AIDD. So as I mentioned, everybody nowadays might be using ChatGPT. So in ChatGPT, you can see here the input language or data annotation which is used is a human language. It may be English, Russian, or any Korean language. So based on this data, the data annotation is done, and the generative pre-trained transformer algorithm models will be predicting new content for us. So similarly, in creative pre-trained transformer, here we are using the chemical language, like chemical structure, or even biological language like protein structure, amino acid sequence. So these data annotation will be in the chemical or biological language, and the output will be like new chemical structure or new SAR, structure activity relationship, or even the new molecular generation. So it's very simple. There is a data algorithm models, and there is a prediction. So further, to understand furthermore, like there is a data aggregation, data available in the public domain, like PubMed, WIPO, Pharmacodia. We have, after this session, there is one more session called Pharmacodia Global, that is a big data. So that data also will consider as an input here. and there is a protein databases like PDB, UniProt. So this data is considered an A algorithm models are built. These algorithm models like molecular fragmentation model, molecular bioassisted recognition model, means functional side chain recognition models. So, and even output what you are getting is a new chemical space for any target or new molecular generation for us. So this is very simple, like even any researcher, I think before going to any research, what he will do the literature survey. So what is the literature survey? So to know what is all the work happened already in that field. So similarly, this AI algorithm models will consider what are data available regarding that, and it will predict for us. And the quality and the quantity of data inputting is very, very important in the AI tool, because we in a layman language you can call it garbage in, garbage out. So the quality and quantity of data what we are using, the accuracy of prediction will be that much good, we can say. So with this question how it works, now we will see some features of this ready to use tool, and it's very easy to use also. The tool name is called Cyber AIDD. So Cyber AIDD, it is it's a first tier sorry for the interruption. So Cyber AIDD is a first tier drug discovery tool for the designing the new molecule and drug target exploration. And it provides it has mainly three core functions. It provides opportunity for discovering the first in class targets and efficiently conducting the STR analysis and innovative structure and lead molecular optimization. So it has two core functions. One is Cyber XSAR we tell. It is just a name we have kept. Cyber XSAR is for target screening and SAR mapping. And Cyber X Discovery for molecular generation tool. It has two subgroups. Cyber X Hit for target based hit library generation and Cyber X Lead for lead compound optimization. So as I told, the garbage in, garbage out, the data what we are considering in the Cyber AIDD is, like we consider the target of more than 10,800 plus targets from 692 species, and even like cluster molecule information of 220,000 plus and 1 million plus target related active molecules, and assay data of 580,000 plus and activity data, and we consider the data from the articles also, like more than 1 lakh articles from 724 journals. And apart from this, we also consider the data of 12,000 drug molecules which are in the market or in the under clinical development. So this is very, very important. So already we are considering the data of successful molecules. So the prediction will be also success assured, we can tell. So this is about the first, some more features of the tool. What we can do, using the tool. We can do the scaffold cluster and chemical space prediction. We can do the target success ranking index. Like any project initiation, you can check whether target which I have chosen for particular indication, whether it will be successful or not. That can be predicted. And prediction of molecular structures associated targets. This is something like already approved molecule. We can also predict a new target, drug repurposing we will call. So this is how it looks. When you enter any target, it will show all the clusters, means which can be a potential ligand for that target. And inside each cluster there is again real structures. So each cluster can be again one project or PhD work or even postgraduate work. You can choose and start working. So this is how the tool makes even the project selection easy, which was very difficult when we were studying our post-graduation projects. So as I told, it will mention each, even real structures in the each cluster structures. So here you can see, like it is arranged according to their developmental status, like approved, preclinical. So again, you can choose any one structure, you can do the bioassociative recognition. There is an option here where you can change the functional groups and see whether activity is decreasing or increasing, and then proceed for the analog synthesis, and go before synthesis you can do docking studies and go for the synthesis and bio studies. So these are the real structures which are arranged according to the clinical phase, and there is a manual labeling is done. Like as we told, we have our own database, so we will also do the manual labeling of the structures. So data mining also done from the literature data. So this was one more which I mentioned, like we can also, before starting any project, you can check whether the target which I have chosen for my project is of what success rate. So this can be also possible. And this is third function, we can predict the new target for the approved molecule. So especially in India right now, a lot of research is going in this area. Like we call it drug repositioning or drug repurposing. Because this research takes very less time. Again, no need to establish the toxicity and studies, because just you prove the efficiency is enough. There are some additional functional specifications, like you can do scaffold, check the scaffold similarity. Choose any structure, you check similar structure or similar scaffold. So this will give the, with the chemist wisdom, he can put his ideas and come up with the new molecules. So already tool show how much similar, like 100%, 97%. So this tool is also linked to PDB. For extracting the coke crystal structures of small molecules which are arranged according to their clinical status. So I think the chemist here can very much correlate how potential this tool can help for their ongoing, as well as if they are initiating any project. So this is the second subfunction which I showed, CyberX discovery. The earlier SAR, this is a database tool where no need of computation. But this second tool, discovery, is a computation tool, but no need of downloading any software. This is also web-based. Just it has two parts, CyberX hit for discovering the hit compounds and CyberX lead for the lead compound optimization. And you just input your seed molecule and also the target, and if you just click on the computation, it will just take 10 to 15 minutes and generate 200 molecules at a time. So with this, I just want to tell the advantages, like the transfer, prediction what is happening is from the real world data. So the drugability properties are inbuilt in this tool. So the drugability, like pharmacokinetic properties, solubility challenges, this is all addressed while the design of the molecules. So coming to the last part, why adopt such tools to our even academic. So right now the global so I'll conclude in 5 minutes. Right now the global pharmaceutical market is enormous. It is evolving, like increasing year by year. So even when it comes to India, the pharmaceutical innovation landscape in India also evolving rapidly, and there is a lot of right now the government initiative driving the innovative policy. Like right now, the 5,000 crores is allocated for this pharmaceutical innovation, which is for the 5 years plan. And there are a lot of funding agencies like Open Source Drug Discovery Initiative by CSIR, and even government has allocated US $46 million for this OSDD project. So like that, there are a lot of, yesterday only they have launched one more initiative like India AI, where we can write the proposal for the AI-driven drug discovery tool. It is collaborating, like we are the pharma domain expert. We can collaborate with the IT guys and bring up some AI tools for addressing the existing problem, solving the problem. So what I want to say is the ecosystem in India right now is very favorable, and if we want to keep the pace with the developing world and we want to be like number one in the race, we must adopt the innovative research in our country also. So such tools will be value addition for such programs. So here are some examples, like already grants have been got use of in silico tools and for the drug discovery. And this is the USA. They have the Academic Drug Discovery Consortium. There are a lot of academic institutions where the early phase drug discovery happens, and they go for filing the patent, and later these patents will be like out licensed to the pharma and biopharma. So the same model we can adopt in our country, where early phase drug discovery will take it in academic level, and once the proof of concept or preclinical candidate is available, the asset can be patented and licensed out. I think this trend will be seen in next 5 to 10 years. So coming to the last individual, like where is the starting point for the academic institutions, especially for the students? So how to start? So like we can use such tools, AIDD and CIDD tools, like using the existing idea. I think some people might be working on some work, or they have some assets with them. They can screen those assets using the tools and further validate it. Second is review the latest approved molecules, and you can bring some analogs of those molecules. Like in 2024, around 10 molecules are approved, and bring some 10 analogs for those molecules. This is one of the starting point we can tell. Then conduct the cyber AID of latest articles. You can refer the latest articles of like in Journal of Medicinal Chemistry. There are many articles, and take those articles and choose those molecules and screen using the tools. So this is the ready-made, what I am telling, that you can take up the project by these points. Next point is like take up the new drug discovery project. This is little difficult right now, but yes, we can take the initiative. I think there is a lot of energy, especially in the young researchers sitting here. We can take the initiative, but of taking up the new drug discovery project. And I think down the line, India will be the also will be the working towards this direction, bringing the new, more innovative molecules. Then cyber AID tool also helps to like drug repurposing, what I told. Already approved molecules are there. Use the tool and validate that this approved molecule can also be used for the new target or new indication, and that can be a drug repurposing work. So these are few, but this is not limited to only 4 or 5 points. There is a lot can be done if the chemist can able to play with using these tools. So with like this example I showed, like bringing up the analogs. This is just 2024 approved one molecules, and they have brought, sorry, in 2012 approved molecule. In 2024 they have brought one analog. So this is possible with the AI-driven drug discovery tools. So there is one more option for the organizations. They can go for like once establishing the center of excellence or in silico laboratory in their organization with such tools like, as I told, Pharmacodia Global, and there is AI-driven drug discovery. There is a computer drug discovery. There is pharmacological tools, and there are many tools coming like pharmacological screening tools, clinical prediction tools. So this can be a one-stop solution for in silico laboratory. So at last I want to say, like we need to be keep updated. Like keeping updated is one of the value to match to the theme of the conference. So keeping ourselves updated to the changing world is one of the very important value, which can make us help us in bringing the innovation, and these innovations can be helping the society, either solving the unsolved problem or like reducing the complexity of existing solution. So with this, I thank the organizers, and now any questions are most welcome.
Thank you, Anil Kumar. Now the session is open, especially youngsters. Most of the time used to be there on chatting using the mobile. It's a very good work. You can utilize this particular technique, and you are having a very good innovative ideas. You can create a very good molecule, and you can give the good contribution to the society. That's what we are expecting. So I'm looking some questions from youngsters, very important, because it is more useful now. Very wonderful talk he gave, and quite appropriate for you people.
If there is no youngsters, the teachers, those who teach the youngsters can raise the question if you are permitted.
No, youngster means mind will be always young. That's most important.
Okay, thank you. So there is a quick two questions to you. One very interesting talk. Can you add up a little more about that ADMET, how this a tool which is going to be help us? ADMET science, I have seen somewhere in we can use this tool even in the ADMET science also, in the ADMET predictions, ADME. Yeah.
Right now, right now in this tool, ma'am, web online we cannot predict. Means still we are working on that. Right now we have kept it for the structure activity relationship analysis, and even like as we are considering the data of successful molecules, some ADMET properties are, we say it is inbuilt, because the molecules which we are considering for the algorithms to predict are already meeting that ADMET and physicochemical properties and even synthesizability difficulty properties. So it is like we say it is already inbuilt. But we are also working, ma'am, back end, like to bring up some more features in the tool where we can it will new generated molecules ADMET will be predicted. Like right now it is not the case.
And my final question is,
yes,
as academician, how it's academic friendly this tool will be?
It's very, I think many chemists might be using CADD tools. Compared to that, it is just like even undergraduate student, just with 1 day of training, he can start playing with the tool. It's very easy. Like, and if anybody is interested, like we will later you can contact us. We will also provide the free trial so that, and followed like demo followed by free trial, so that you can validate your existing work using this tool. Yeah.
Right. See, it had been a wonderful presentation, and I'll just add, or briefly summarize what he has said so that you will follow in simple language. Forget AIDD, AID will remember of AIDS. This is artificial intelligence for drug discovery. We are attending this conference. Our goal as a pharmacist, as scientist, is to discover new drugs. Now we are going to apply artificial intelligence for drug discovery. Now how to do that? A day is not far off. We will not have scientists now discovering the drugs anymore. We are going to have artificial intelligence companies. These companies will discover the drug. I'll tell you, for academics or for the students, how this will help. What you do when you take up a research project, what is the first thing you do? You do literature survey, right? You do literature survey, what is reported in the literature. You don't need to do that now at all. Those 6 months not required. This tool, within 24 hours, actually within minutes, it will give you entire literature that is available. It also depends what you want, what your objective, accordingly you have to feed in. There will be developments. It's in the initial stage, I understand. I was with the speaker last evening, and he said, you give me interested universities, technical institutions, which want to discover new drugs, which want to have a tie-up with companies, will go and train the students, will train the faculty, and within 24 hours, this is what it's a wonderful, and it's going to make who are interested in doing work, those who want to patent their work, for them it is depressing. We talk of Einstein, Isaac Newton. In those days, literature survey, Google, etc. was not there. But now AI is going to do everything. These lead molecules are being patented. It's not a drug. It's just a molecule from which you will get a drug. It will be an analog or a derivative of that molecule. This is the way research is going on. So younger generation, now you should use this mobile for identifying lead molecules, patent it, company will take it, and maybe one drug comes out to be a wonderful medicine, for treating such diseases, say autism, cancer, AIDS. We don't have a treatment, and thousands of compound in minutes they'll predict which is effective. Then you can take it for clinical trials. This will not replace clinical trials. That will have to do in any case. But then the preclinical testing task, that would be reduced. Isn't it?
Yes.
Am I right?
Yes.
Right, thank you.
And one good thing is that earlier one project at a time we could able to do, but now at a time we can do a 10 project because it is saving a lot of time for your whatever the literature survey and kind of things. Yes.
I think session is, if you are having any queries, you can ask later because running short of time. So we'll wind up this session. So on the behalf of APSECON and Sarada Vilas of Pharmacy College, wonderful talk, more appropriate talk to this session for budding pharmacists.
Thank you, sir. It's a pleasure to have Mr. Anil Kumar Ranadev sir with us today. I request sir to kindly accept our token of appreciation, and I request our chairpersons to do the honor by handing over a memento to sir. Thank you, dignitaries. I'd also like to thank Dr. Kiran Kumar Hullati sir and Dr. Gururaj sir for chairing the session. May I request Dr. Nagendra R sir and Dr. Shailendra Gurav sir to hand over the memento to our chairpersons and honor them. Thank you, dignitaries. Lunch has been arranged in the main building. I request the gathering to kindly accept the same and gather back here within half an hour. I repeat, lunch has been arranged in the main campus. I request the gathering to kindly have the same and gather back here within 2 o'clock. Thank you.
Hello. Check. Hello. Check.
Hello. Hello.